Evening everyone, and welcome back to the day 2 of Diagnosis of Lymphomas. Hear it from the experts. I am Dr. Amrita Sao, Senior Resident at Department of Pathology, Amrita Institute, Kochi. So without any delay, we start with our first session. For our first session, I invite Dr. Geeta Vidyadharan, Associate Professor Pathology, Amrita Institute, Kochi, to introduce our moderators. Madam has specialized in hematopathology and have received training from the prestigious Tata Memorial Hospital, Mumbai. So I welcome Geeta ma'am. Ma'am, welcome. Over to you.
Thanks, Amrita. Consider my privilege to introduce the moderator for the first session, Dr. Nair Dr, who is acquainted with all of us, being an expert in her interest area. Madam is a graduate to Convent Medical College, Kottayam, and did her MD and is an alumni of Calicut Medical College. She's worked at Amala Cancer Hospital, Thrissur, and then from there she's joined CMC Vellore, where she serves as a full professor. Currently, she is on a sabbatical and works as consultant histopathologist at Maidstone Hospital, Kent, UK. Her areas of interest include breast and endocrine pathology, apart from lymphomas, all of which she has many in national and international publications from. Welcome, madam.
Welcome, thank you. Hello, and thank you for that introduction. Thank you for the invitation. It's my pleasure to moderate this session and introduce the next speaker, Dr. Jayalakshmi Balakrishna. She's currently assistant professor at Ohio State University, Department of Pathology. She graduated from IAPM Medical College and did her post-graduation at Christian Medical College, Vellore, India. And then she did her anatomic and clinical pathology residency at Mount Sinai, New York, followed by hematopathology fellowship and basic degree in immunology from NIH Bethesda. She's got a lot of publications to her credit and has won a lot of awards. And Jayalakshmi was our postgraduate student at Christian Medical College, Vellore. She was one of our brightest and most industrious trainees. And we at CMC look with great pride and joy as she follows a passion of hematopathology. Today she'll speak on aggressive B-cell lymphomas, which is a common diagnostic problem encountered by specialists and non-specialists alike. And we are looking forward to hearing from you. Thank you so much. And over to you.
So first, let me share the screen. And so is my screen online now?
Yes, ma'am. Yes, ma'am.
Okay, thank you so much. So hello, everybody, and thank you so much for the kind introduction, Dr. T Manipandam. Marie is, like she mentioned, was attending when I was doing postgraduate training at CMC Vellore. It was the best teaching I have ever experienced, and all my interest in pathology and hematopathology came from that basic pathology training I got there. And I was just telling the panelists when we were chatting before the session that Marie, of course, was one of the reasons I chose hematopathology. Her efficiency and the interest and passion towards pathology, it was something to look up to and follow. And I'm glad I chose the subspecialty and I could pursue the training I wanted in that. So with not much of chit chat, I'll go ahead and start with the talk. So thank you so much, IAPM, for the opportunity to do this course. And most importantly, thank you all for the audience for coming to my lecture this late in the evening for you. So what I'm going to do is I'll just give an overview of aggressive B-cell lymphomas with not much of nitty-gritty details. And this will be based on the WHO 2017 revision or 2016 revision, which came out in 2017 early. And I will emphasize on therapeutic and prognostic implications of the diagnosis we make. And what we are going to do is we'll focus on diffuse large B-cell lymphoma, not otherwise specified, and its differential diagnosis and similar entities, because that is where like a little bit of confusion is there in terminology and the definitive diagnosis. And I want to include immunodeficiency associated lymphoproliferative disorders, even though there are like aggressive B-cell lymphomas under that heading, because that will be done by Dr. Eve Marie Crane tomorrow. And at the end of the talk, this is a short talk, and at the end of the talk, I'll give you a very short summary of, not very short summary, but a short summary of what I talk during the hour. And then at the end of the talk, I'll give you some key take-home points. So my goal is that at least some very important points you will, particularly the junior level trainees, will have in mind once we are done with this talk. The lecture I've made in a case-based format, so that I'll show you a case and then we will discuss it. But we won't again go into the extreme details of the cases. I'm hoping, I'm sure we will have, because I made a short talk, we will have some time and I'll give you a couple of bonus cases as well. So assuming that sounds like a good plan to everyone, let's move on to the actual lecture. The current WHO classification recognizes these entities, the table here, this is from the WHO classification, as aggressive B-cell lymphomas that we all know. So they are the diffuse large B-cell lymphoma, not otherwise specified, and its subtypes, Burkitt lymphoma and high-grade B-cell lymphoma subtypes, and plasmablastic lymphomas. And then there are more distinct lymphomas which are classified based on their localization, genetic changes, or infectious agent association. So these are the aggressive B-cell lymphomas. We won't go into every single entity under these, but I'll try to cover most of them. So it's good to have a broad classification of the entity, like, you know, a group of entities or differential diagnosis to consider in mind when we first look at the morphology of a case. So when I start looking at a case, I think about the more broad morphology subgroup of the lymphoma I'm looking at. So the three subcategories or morphologic subgroups I usually put cases under are, like when I start a case, diffuse large B-cell lymphoma like morphology. That's like large cells, pleomorphism, variable nuclei, sometimes prominent nucleoli, things like that. And then a Burkitt-like or blastoid morphology. That's again intermediate sized cells, finely clumped chromatin or dispersed chromatin, not so prominent nucleoli. Some of them might have nucleoli, and that telltale starry sky pattern, the basic high-grade morphology. And then plasmablastic or immunoblastic morphology. So these are the three different categories I consider when I look at a case. Now let's move on to the first case. So this is a 58-year-old female with a right cervical lymph node. Again, we are not going into the extreme details of clinical presentation, imaging findings, past history, all those things, because we are looking at aggressive B-cell lymphomas. Let's consider all these patients presented with symptoms of, or at least symptoms suggesting an aggressive lymphoma. So here, what we are seeing is a proliferation of, a diffuse proliferation of atypical cells, which are large in size. There is considerable pleomorphism. Cells are chromatin is vesicular, and there are nucleoli, variably prominent, right? Variable number and variably prominent nucleoli in most of these cells. And the neoplastic cells are obviously CD20 positive. We are talking about B-cell lymphomas, and they are expressing BCL6 as well. Then they are BCL2 positive and CME positive. They are expressing MUM1. The Ki67 shows a very high proliferation rate. And CD3 is negative, CD10 is negative, and EBER is negative. We do FISH, and FISH came back negative for BCL2 and MYC rearrangement, but BCL6 was rearranged. So you are all right. It is a diffuse large B-cell lymphoma, not otherwise specified, non-germinal center phenotype, with expression of BCL2 and CME, the so-called double expressor phenotype. So I'll let you put that diagnosis in mind once more. We put the diffuse large B-cell lymphoma category, not otherwise specified. It's cell of origin subtype, which is non-germinal center, and we need to mention that double expressor phenotype. So with that case in mind, let us look at other entities which I would put in the morphologic box of diffuse large B-cell lymphoma. That is the large cells, nuclear pleomorphism, variable clumping of chromatin, and variable prominent nucleoli. Large cell size is defined as larger than a normal macrophage nuclei or more than twice the size of a normal lymphocyte. This would include diffuse large B-cell lymphoma, not otherwise specified, and its subtypes, T histiocyte-rich large B-cell lymphoma, EBV positive diffuse large B-cell lymphoma, pleomorphic mantle cell lymphoma, high-grade follicular lymphoma, and other specific or distinct subtypes of large B-cell lymphomas. So these are the entities we are going to look at right now. When we see a diffuse large B-cell lymphoma, not otherwise specified, we need to subclassify them based on the cell of origin. That is germinal center B-cell versus non-germinal center B-cell type. There are several immunohistochemical algorithms published for this, but the most commonly used one is Hans algorithm, which is actually a reasonable surrogate for the cell of origin classification by gene expression profiling. Gene expression profiling and immunohistochemical algorithms do not always match. And if we use different algorithms, the cell of origin classification may be different in the same lymphoma. But it is acceptable and good enough or reasonable classification to use in a clinical setting. For Hans, we use CD10, BCL6, and MUM1 to differentiate the two entities. And if the cells are CD10 positive, they are germinal center B-cell type. If they are CD10 negative, look for BCL6, and BCL6 is negative, it becomes non-germinal center. If it is positive, look at MUM1. If positive, non-germinal center B-cell, and if MUM1 is negative, it is germinal center B-cell type. This is a good classification to use in the clinical setting. Germinal center B-cell shows significantly better prognosis than non-germinal center B-cell type. That's why we need to do this classification. And in addition to that, prognostic importance, there are newer therapeutic options with preferential activity in germinal center B-cell versus non-germinal B-cell center B-cell types. So it is important to classify that. Then now with newer technologies, we have gene expression profiling subtypes defined. They are germinal center B-cell type, stromal 1 and stromal 2, which have definitive prognostic differences. And by mutational analysis, there are genetic subtypes, definitive genetic subtypes as well, which are also distinct prognostic entities. Then, in addition to this cell of origin classification, we need to do BCL2 and CME. And CME cutoff usually uses 40%, and BCL2 cutoff usually uses 50% to see their expression. And if both are expressed at protein level, this is a double expressor phenotype, which has a significantly lower overall survival rate compared to the negative ones. The next entity, the first entity, right? We just saw a not otherwise specified diffuse large B-cell lymphoma. The first one, the specific entity is T-cell histiocyte-rich large B-cell lymphoma. This is more or less very similar to a not otherwise specified type, but it is a very distinct morphologic entity. The tumor is composed of the T-cell and histiocyte-rich large, like a dense background, and very scattered and rare, smaller number of neoplastic cells, which are large and pleomorphic, scattered throughout the tumor. And the lymphoma cells are morphologically almost always similar to a diffuse large B-cell lymphoma, not otherwise specified, but they can show very variable morphology and even can have Hodgkin-Sternberg-like cells. The immunophenotype is similar to diffuse large B-cell lymphoma, not otherwise specified, and EBV is negative. Then comes the EBV positive diffuse large B-cell lymphoma, not otherwise specified, which is a separate diagnosis. And if the neoplastic cells are positive for EBV in a diffuse large B-cell lymphoma, this diagnosis needs to be made regardless of the cell of origin subgroup or expression of MYC. These lymphomas generally show a very reactive background. They can show a spectrum of morphologic features, including a subtype resembling T-cell histiocyte-rich large B-cell lymphoma. So EBV is positive in this. So if all the or most of the neoplastic cells are positive in a diffuse large B-cell lymphoma, then it becomes EBV positive diffuse large B-cell lymphoma. Then an important differential diagnosis to keep in mind when we look at a lymphoma with diffuse large B-cell lymphoma like morphology is pleomorphic mantle cell lymphoma. This has a very different therapeutic approach from that for diffuse large B-cell lymphoma, not otherwise specified. Flow cytometry is performed. Not all cases of lymphoma, particularly if it is a needle core biopsy or a tissue which was suspected for a somatic malignancy, you may not have flow cytometry associated with the lymphoma biopsy. But if there was a flow cytometry performed, it should show CD5 positivity in most cases of mantle cell lymphoma. Then we can suspect this. And we, of course, need to confirm the diagnosis with cyclin D1 and or SOX11. And these lymphomas can be morphologically indistinguishable from diffuse large B-cell lymphoma, not otherwise specified, or similar entities, and can be CD5 negative. So it is important to keep this entity in mind, because if we don't specifically look for them, we might miss them. And if cyclin D1 and SOX11 are negative in a CD5 positive large B-cell lymphoma, a diagnosis of CD5 positive diffuse large B-cell lymphoma is made, which is a distinct clinicopathologic entity. Typically, these cases show higher prevalence in Asian population. Most are of non-germinal center B-cell type, and most importantly, show a worse outcome compared to diffuse large B-cell lymphoma, not otherwise specified. So CD5 positivity, two entities to keep in mind: pleomorphic mantle cell lymphoma and CD5 positive diffuse large B-cell lymphoma. Then another entity I always consider in the differential diagnosis when I see a large cell lymphoma with vague nodularity or even without any apparent nodularity is high-grade follicular lymphoma. It is important to differentiate high-grade follicular lymphoma, particularly the grade 3A follicular lymphoma, from diffuse large B-cell lymphoma, because grade 3A are treated differently from grade 3B or diffuse large B-cell lymphoma. So I always do an FDC marker like CD21 or CD23 to make sure there are no mesh works. This one is a grade 3A follicular lymphoma. See the CD20 staying here, and this is a grade 3B follicular lymphoma, and both these cases did not have any apparent nodularity or definitive nodularity in morphology evaluation. And both these cases were diagnosed as diffuse large B-cell lymphoma in needle core biopsies. So that is a pitfall in diagnosing lymphoma in needle core biopsy. So because if the needle goes through between two nodules, we won't see the actual nodule. It is going through the internodular area, and we won't see the actual nodule, and we will go ahead and call them diffuse. But see the CD21 in the grade 3 with this one, see there are nice nodularity, and in the excision there were no diffuse areas at all. So this is one thing we need to keep in mind, particularly if you see any degree of vague, at least vague nodularity, or when you see a typical follicular lymphoma immunophenotype in a large B-cell lymphoma, remember to rule out high-grade follicular lymphoma. Then the next specific or distinct large B-cell lymphoma, depending on the clinicopathologic features, is primary mediastinal large B-cell lymphoma. This is in an appropriate clinical setting, and these PMBLs usually show a nesting pattern with clear cytoplasm. That's the classic morphology described, right? And the immunophenotypically, they commonly express BCL6 and MUM1 together, non-GCB phenotypes commonly, but they express BCL6 along with the MUM1. And majority of these cases, or a large number of cases, are CD23 positive, which is actually a good diagnostic marker for PMBL. And Another important stain to consider in PMBL is PDL1 because of its therapeutic implications. The thing to remember here is PMBL can be extra-mediastinal. So being within the mediastinum is not a make or break deal in the diagnosis of PMBL. The next subtype of specific large B-cell lymphoma or distinct entities, intravascular large B-cell lymphoma. To make this diagnosis, the majority of the tumor cells need to be located within vessels. Like in this particular case of a young woman with an endometrial polyp who just presented with vaginal bleeding and was found to have a small endometrial polyp, has these very subtle atypical lymphoid infiltrates within the endometrial polyp. And these tumors are very aggressive and very often diagnosed only on autopsy. So it is important to keep this in mind when you are looking at biopsies. If you see atypical cells and if you see them within vessels, think about this and do the stains and further workup. To confirm the intravascular location, we may need to do CD34 or CD31, the endothelial markers. The last subtype of specific large B-cell lymphoma I have included in this category is primary CNS large B-cell lymphoma. This can form large diffuse masses replacing the brain matter, but mostly show these perivascular accumulation of tumor cells, like in here, this case. And they are mostly of non-germinal center B-cell type, expressing again BCL6 and MOM1 together. And CD10 is absent in the majority of the cases. If we see an isolated CNS large B-cell lymphoma with CD10 expression, a thorough workup to rule out systemic lymphoma is necessary before making the diagnosis of this primary CNS large B-cell lymphoma. The majority of the primary CNS large B-cell lymphoma will also express CMYC, that is the MYC and BCL2 expression double expressor phenotype. So that is the large B-cell lymphoma, diffuse large B-cell lymphoma morphology subgroup, like the large cells, pleomorphism, mostly vesicular or variably clumped chromatin and variably prominent nucleoli. Now let's move on to the next case. This is a abdominal mass from a 65-year-old male. This patient presented with multiple abdominal masses and omental deposits. So obviously the clinical thought was this is a, like a colon cancer or something like that. And here, let's pay attention to the morphology, right? So this is again a diffuse proliferation of kind of medium-sized or intermediate-sized cells with more or less uniform appearance, and the chromatin is like finely clumped or finely dispersed, and nucleoli, there are multiple nucleoli and they are variably prominent, not like staring at your face nucleoli, right? There are a lot of tingible body macrophages. See the telltale great, we all know about the starry sky pattern. So that is there. And the tumor cells are obviously CD20 positive and CD3 negative. We are talking about B-cell lymphomas again. They are CD10, BCL6 positive. They express CMYC and BCL2 is negative. MOM1 is negative and Ki67 shows a very high proliferation rate. EBER is negative. I'm sure now the first year PGs are screaming the diagnosis. But wait. Fish came back and both BCL2 and CMYC are rearranged. So that is a high-grade B-cell lymphoma with MYC and BCL2 and or BCL6 rearrangements. In other words, it is a double hit lymphoma. So this morphology, this is double hit lymphoma, right? So think about that Burkitt-like morphology. So when we look at Burkitt-like or blastoid morphology, right? Like blastoid, fine chromatins, small to intermediate size cells, can cytoplasm, very young looking cells, and with high proliferation rates and starry sky pattern, we need to consider entities like Burkitt Lymphoma, Burkitt Lymphoma with 11q aberrations, which is a provisional entity in the current WHO classification. Of course, acute lymphoblastic leukemia lymphoma, then high-grade B-cell lymphoma subtypes, which are high-grade B-cell lymphoma with double or triple hit, and the high-grade B-cell lymphoma not otherwise specified. But we need to consider blastoid mantle cell lymphoma as well when we see this blastoid or intermediate morphology. So Burkitt lymphoma, I don't think we need to go into the details at all because everybody knows about Burkitt. They have mostly intermediate size cells, which are more or less uniform in appearance, finely dispersed chromatin, and multiple nucleoli. They show very high proliferation rate, express CD10 and BCL6, and are negative for BCL2, the classic phenotype of Burkitt. But we need to keep in mind BCL2, some degree of BCL2 staining, that's weak, variables, a few cells positive, that's acceptable for Burkitt. CME is expressed at protein level, and there are mixed gene rearrangements. EBV may be positive depending on the subtype of the Burkitt. And Burkitt-like lymphoma with 11q aberration is exactly what the name suggests. It resembles Burkitt by morphology and immunophenotype, but are negative for CME rearrangements and show abnormalities of the chromosome 11q. Acute lymphoblastic leukemia lymphoma, on the other hand, has small to intermediate sized cells, blastoid morphology, and show high proliferation rate. They express markers of immaturity, that's CD34 TDT. Most cases are TDT positive, but there are TDT negative cases. But we need to remember morphologic and immunophenotypic variants also exist. So there may not be like a very good expression of immature markers. They might express more mature B-cell markers like CD20. So these differences will be there, and TDT negative cases are there. By morphology, there might be significant pleomorphism as well in lymphoblastic leukemia lymphoma. So these pitfalls we need to keep in mind when we look at these cases. Next comes the confusing entity, high-grade B-cell lymphoma, not otherwise specified. So this is the new kid in the block, and the diagnostic criteria is these show features of like the morphologic features, right? Similar to Burkitt, or show an intermediate morphology between Burkitt and diffuse large B-cell lymphoma. In other words, if a lymphoma looks like diffuse large B-cell lymphoma, you look at a lymphoma and the first thing coming to mind is diffuse large B-cell lymphoma. Large cells, pleomorphism, prominent nucleoli like vesicular chromatin, all those things, then it is not a high-grade B-cell lymphoma. It is a diffuse large B-cell lymphoma. But you look at a aggressive B-cell lymphoma, and it has either blastoid or Burkitt-like morphology, or even intermediate like morphology between diffuse large B-cell lymphoma and Burkitt, then it becomes high-grade B-cell lymphoma, not otherwise specified. Immunophenotypically, it can resemble Burkitt or diffuse large B-cell lymphoma. And important thing to remember, it lacks MYC, BCL2 and or BCL6 gene rearrangements. That is what it is differentiated from Burkitt or the double hit, triple hit types. If that rather quick and superficial description was confusing to some of you, let's go over this famous flowchart, right? The smart people who figured this flowchart divided 4 morphology categories, that is blastoid, Burkitt lymphoma like, diffuse large B-cell lymphoma, intermediate between Burkitt lymphoma and diffuse large B-cell lymphoma, and the like frank diffuse large B-cell lymphoma like morphology. And then they put colored arrows like these, indicating the cytogenetic or immunophenotypic features. The blue arrow is there is no cytogenetic or fish abnormality. Orange or yellow, these arrows means isolated MYC rearrangement, and the red arrows is for double hit or triple hit. Sorry. So, if a lymphoma is blastoid in appearance and does not have any of the fish or cytogenetic abnormalities as MYC, BCL2 or BCL6 gene rearrangement, and it is TDT positive. Remember the clause, it has to have TDT, then it is blastic lymphoma leukemia. If it is blastoid but TDT negative and cyclin D1 negative and no MYC or BCL2, BCL6 rearrangements, it becomes a high-grade B-cell lymphoma, not otherwise specified. But if it has hits and TDT is negative, it is double hit or triple hit lymphoma. However, there are a small group of ALLs, like I mentioned before, which are TDT negative. So this article is very good to read about TDT negative acute lymphoblastic leukemia lymphomas, and a small percentage of high-grade B-cell lymphomas, which are TDT positive, are also there. So practice caution and put the whole picture together to make a definitive diagnosis in this kind of entities. And this is also a place to watch out for changes in the next WHO edition. Then the next morphologic subgroup is Burkitt lymphoma like morphology, right? If this has isolated MYC, it is Burkitt lymphoma. And if it has hits, it's again double hit or triple hit. If there are no hits, I would do an 11q testing before making a diagnosis. And if there is still nothing, then put them in the high-grade B-cell lymphoma NOS category. Then comes the morphology group, which is intermediate between Burkitt lymphoma and diffuse large B-cell lymphoma. Here, the points to pay attention to are: 1, intermediate morphology means intermediate between Burkitt lymphoma and diffuse large B-cell lymphoma in the cell size, nuclear features, nucleoli, and pleomorphism. 2, intermediate sized cells with all other morphologic features. For example, significant pleomorphism is there, should still be under the frank diffuse large B-cell lymphoma morphology. Just the tumor cell size won't put it in the intermediate category. 3, Burkitt can have a certain degree of pleomorphism. Burkitt is not like, it's not mandatory for Burkitt to be very uniform cookie cutter cells. It can, a certain degree of pleomorphism is permitted in the diagnosis of Burkitt, particularly true in adult cases of Burkitt, HIV positive patients, and post-treatment recurrences. So points to those who noticed the pleomorphism in the Burkitt case I showed you earlier. That case actually is an HIV positive adult patient and a post-treatment recurrence of Burkitt lymphoma. It was very pleomorphic actually. So a tumor with this intermediate morphology has no hits. It is a high-grade B-cell lymphoma, not otherwise specified, right? Like this. And then if it has isolated MYC rearrangement, it is Burkitt lymphoma. And if it was double hit or triple hit, it is under that category. Now comes the frank DLBCL morphology. If these cases have no hits, again, it goes to diffuse large B-cell lymphoma, not otherwise specified. If they have isolated MYC, it is again diffuse large B-cell lymphoma, not otherwise specified with isolated MYC. And if it has double hit or triple hit, it is to be put under that category. So this double hit, triple hit lymphomas can have significant pleomorphism in some cases and can be indistinguishable morphologically from diffuse large B-cell lymphoma. Double hit and triple hit fish is another area. There might be changes in the upcoming WHO edition. There are discussions about how BCL6 is not all up there in the prognostic differences in these categories. So watch out for those changes as well. Then that brings us to the cyclin D1 clause here, right? I will add SOX11 to it because not all cases of mantle cell lymphoma are cyclin D1 positive. And when you see a blastoid or intermediate morphology, think about blastoid mantle cell lymphoma as well. So blastoid mantle cell lymphoma would show, as the name suggests, blastoid cells with very high proliferation rate. We can confirm the diagnosis with CD5 stain. We need to keep in mind sometimes CD5 can be negative. Then by cyclin D1 and SOX11, and if needed, we need to do FISH for cyclin D1 rearrangement. So this is, I'm sure you are all familiar with this molecular progression of mantle cell lymphoma diagram. I'm showing this to remind you about the importance of TP53 in mantle cell lymphomas. It is important to do the stain or gene analysis in mantle cell lymphomas for TP53 because alterations in TP53 are associated with disease progression and poor prognosis. So that's an overview about the blastoid, Burkitt, or intermediate morphology group of lymphomas. Then let's move on to the next case, which is a perforated duodenum from a 45-year-old female, which came as a case transfer from the GI path service because it was a resected duodenum with no previous diagnosis and of course with 90 slides. Then here we see the diffuse growth pattern, right? It is again like the other lymphomas we saw they are diffuse. And look at the cytoplasm. They have very amphiphilic cytoplasm, eccentrically placed nuclei, and very coarsely clumped chromatic. And most of these cells, if you look at them carefully, have very prominent nucleoli as well. The cells express CD45. They were CD20 and CD3, both negative. But they were positive for BCL2 and MOM1. They had cytoplasmic lambda light chain restriction. CME is positive. They are positive for EBER. VS38C is positive and they show a very high proliferation rate with Ki67. So you are all correct. It is a plasmablastic lymphoma. So with this case, let's move on to the third morphology category, right? Which is plasmablastic and immunoblastic morphology. These cases show, like the case we saw, large cells with ample amounts of cytoplasm, eccentrically placed nuclei, and most of the cases will show, or almost all the cases will show, very prominent nucleoli. The differential diagnosis to consider here would be plasmablastic lymphoma, plasmacytoma, or plasma cell myeloma with anaplastic or plasmablastic features, ALK positive large B-cell lymphoma, primary effusion lymphoma, HHV8 positive diffuse large B-cell lymphoma not otherwise specified, and diffuse large B-cell lymphoma not otherwise specified with immunoblastic morphology. Diffuse large B-cell lymphoma not otherwise specified with immunoblastic morphology is not a definitive prognostic or therapeutic subcategory, but morphologically it is distinct. And this needs to be considered as a differential diagnosis when we see a plasmablastic or immunoblastic morphology. So when we see a tumor with plasmacytoid appearance, think about a plasma cell tumor first. Plasma cell myeloma usually show negative, or like I'm not talking about the regular myeloma we see in the clinic usually, the mature plasma cells. I'm talking about the ones which are anaplastic or plasmablastic, right? Those are the things we are considering under this group. So they are, even the regular myeloma, they are usually dim or negative for CD45 and are EBER negative. They express plasma cell markers like CD138 and they are typically negative for CD20. There are cases which express variable CD20 as well. They have intracytoplasmic immunoglobulin light chains, and they may show aberrant expression of CD56 and CD117. However, these cases can rarely express CD45. So, like, it is not necessary that all plasmacytoid or plasma cell tumors be CD45 negative or dim. They can have diffuse CD45 positivity. And there are reports of typical cases of plasma cell myeloma with anaplastic morphology, which are positive for EBER as well. So these two things, CD45 or EBER or even CD56 or CD11 staining, do not differentiate between a plasmacytoma or plasma cell myeloma from a plasmablastic lymphoma. So this is another situation where we need to put the findings in context to make the final call. In this category, the next entity we need to consider is an ALK positive large B-cell lymphoma. This is a rare tumor, but I think that morphology is kind of characteristic. When you see this uglier tumor, which is lymphoma, we need to think about ALK positivity in that. So the morphology is like monomorphic, large immunoblast or plasmablast-like cells, and they may show a sinusoidal growth pattern. The cells express CD45, EMA, MUM1, and CD138, but are pan-B cell markers. Most of the pan-B cell markers are negative in these, and usually they are CD30 negative. A very good stain in this setting is OCT2. ALK-positive large B-cell lymphomas are generally OCT2 and BOB1 positive, even though other pan-B cell markers are negative in these. And obviously, ALK is expressed, that is there in the name itself, and most of the cases harbor the 270 translocation. Next comes the primary effusion lymphoma, which is usually limited to serous effusions, but are rarely solid mass and can be, but they can be solid masses and can be extracavitary. So these are HHV8 associated and are EBV positive. Here again, the cells are large and plasmablastic or immunoblastic, and they usually express CD45, most of the time variable, but still CD45 positive. They are negative for pan B cell markers. That is an important thing. They don't express B cell markers, but they express MUM1, EMA, CD38, CD138, and most of the time CD30. And they have the specific lambda light chain restriction as well. Next, the last entity in this morphology subcategory is HHV8 positive diffuse large B-cell lymphoma, not otherwise specified. This commonly occurs in association with HHV8 positive multicentric Castleman disease, but similar cases have been reported without associated Castleman disease as well. The cells are large and plasmablastic, like you can see here in the high power, and they are usually negative for pan B cell markers and plasma cell markers. But CD20 can be variably positive. Most of these cases express at least some CD20. And these are usually EBV negative, but rare cases with features consistent with this entity have been reported, which were EBV positive. This Dr. Vega's paper is actually a good one to look at the HHV8 positive tumors. And when they have both EBV and HHV8, we need to consider PEL, the primary effusion solid variant of PEL in the differential diagnosis. And so that's about HHV8 positive diffuse large B-cell lymphoma, not otherwise specified. And these are the three broad morphologic subdivisions we can consider when we start with the case of large B-cell lymphomas. So I hope that was that gave you an idea about overall idea about large B-cell lymphomas. And let me give you a small summary. To summarize the terminology we use, diffuse large B-cell lymphoma morphology is that of diffuse large B-cell lymphoma not otherwise specified and similar entities like we discussed, the large cell size, pleomorphism, variably chromatin, variably prominent nucleoli. And high-grade morphology includes Burkitt-like, blastoid, or intermediate between Burkitt and diffuse large B-cell lymphoma. Double expressor is when MYC and BCL2 are expressed at protein level, whereas double or triple hit is FISH or karyotype diagnosis and needs to have gene rearrangements. High-grade B-cell lymphoma NOS is a specific category now, and all the aggressive B-cell lymphomas we cannot. High grade is not anymore a prognostic type. I mean, prognostic type in the same sense, we cannot apply that high grade B-cell lymphoma as a broad category. That's why everybody is calling those entities aggressive B-cell lymphomas now. High grade B-cell lymphoma, NOS is a specific category, and it is the one with high grade morphology, but they lack the gene rearrangements. Why are we making this differentiation? The reason is they are prognostically and therapeutically significant, these differences. The regular diffuse large B-cell lymphoma, not otherwise specified, is usually treated with, or at least first line treated with, a regimen like R-CHOP. Whereas double hit, triple hit will require more aggressive approaches like an RFO. And for high-grade B-cell lymphomas, currently clinical trials are the ones recommended. In other words, there are no definitively defined treatment for this category still. But these are like aggressive regimes like R-EPOCH and other similar ones are being tried at different centers. So it's good to know what is the hematology oncology group in your place using for each of these categories, so that we can cater to their requirements. Then, to summarize the workup required in these cases, first thing to remember is these entities may show overlapping morphologic and immunophenotypic features. What is the most important thing required of us is to provide the treating physician a sensible diagnosis and adequate information for therapeutic decision making and determine the prognostic category. For that, a diffuse large B-cell lymphoma not otherwise specified need to be classified based on the cell of origin. This is done in a clinical setting by the immunohistochemical markers, which is a good but not perfect surrogate for gene expression profiling. We can use HANS or any similar algorithm for this. Do CD10, BCL6 and MAMA and classify them. Then by gene expression profiling, like I discussed before, there are 3 subtypes of DLBCL identified currently, that is GCB, stromal 1 and stromal 2 types. Then mutational analysis identifies several genetic subtypes, which are also distinct prognostic categories like MCD, BN2, N1, EZB, all those things. All these have prognostic significance, but currently in a clinical setting, doing a cell of origin classification by IHC as part of the first diagnostic workup. We also need to do BCL2 and MYC to categorize the double expressor lymphomas, which show a poorer prognosis. In addition, CD5 is a good addition, which will help to distinguish the CD5 positive diffuse large B-cell lymphomas and mantle cell lymphoma subtypes. For confirmation of mantle cell lymphoma, cyclin D1 and SOX11 are used. In our division, every aggressive lymphoma or every aggressive B-cell lymphoma get a TDT stain, keeping the caveat of TDT negative ALLs and TDT positive high-grade B-cell lymphomas in mind. This will help us pick out the odd lymphoblastic lymphomas, which might look like an aggressive mature B-cell lymphoma. Again, all our B-cell lymphomas get an EBER, and I do suggest EBER be done in every single case of an aggressive B-cell lymphoma. Then CD30 can be expressed by diffuse large B-cell lymphoma cases, particularly those with anaplastic morphology. The prognostic significance of CD30 is a bit controversial, but CD30 can be an important therapeutic target, particularly in recurrent refractory cases. If classic follicular lymphoma phenotype or suggestion of nodularity in morphology is seen, rule out high-grade follicular lymphoma by doing follicular dendritic cell meshwork markers. If the specific entities like EBV positive diffuse large B-cell lymphoma are ruled out, T-cell histiocyte rich large B-cell lymphoma is a morphology diagnosis. Then FISH for MYC, BCL2 and BCL6 is an important ancillary test we need to do. This can be done in one step, like do all the 3 together or do MYC first, and if it is positive, then reflex to BCL2 and BCL6. For mantle cell variants, preferably evaluate TP53, like we discussed. Then always keep the specific subtypes of aggressive B-cell lymphoma, like the mediastinal or CNS or intravascular, all those things in mind, and do appropriate stains and look at the clinical history, imaging, all those things. And the main thing is, if the morphology and immunophenotype do not make sense, think about non-lymphoid entities as well. Then, for a lymphoma with plasmablastic or immunoblastic morphology, keep in mind a good number of entities under this category can be pan B-cell markers negative, like we saw. And here, stains to the rescue most of the time are CD45 and plasma cell markers. So if you are looking at the lymphoma and nothing is coming up, remember to do plasma cell stains. Then do CD30, ALK1, HHV8, and EBER for subcategorizing the entities with this classic morphology. If HHV8 and PEL are ruled out, and there are no definitive features to differentiate between plasmablastic lymphoma and anaplastic myeloma, a descriptive diagnosis of plasmablastic neoplasm is acceptable. It's just acceptable, but it is acceptable. with that, the lecture part of the show is over. And because you all sat through this patiently, I will show you a couple of bonus cases. So this is a boy, a small boy with bilateral tonsillar enlargement, which shows these expansile follicles, which are composed of large atypical cells, and they are positive for CD20, CD10, BCL2, BCL6, and MUM1, and CD21 shows retained, slightly disrupted FDC meshworks. So what's your diagnosis? Is it a pediatric type follicular lymphoma? Is it a follicular lymphoma? Is it a large B-cell lymphoma with IR rearrangement? Or is it a diffuse large B-cell lymphoma? Could we please get the first poll?
Ma'am, just let me know when to stop the poll, ma'am.
Yeah, I think we can stop it now. Okay. So the majority called it pediatric type follicular lymphoma. I think I can. Okay. So it actually is a B-cell lymphoma with IRF4 gene rearrangement. Here, the FISH analysis using a break-apart probe for IRF4 on chromosome 6, right, shows telomeric signal, loss of telomeric signal. See, this is a normal signal, the red and green together. Telomeric signal is red and the IRF4 is green. And a single green signals, that is only IRF4 is there, and the red signal, which is telomere, is gone. And the normal is co-localization. These signals are seen. And these cases are very rare, common in children, and mostly affect the Walder ring area or head and neck area, children and young adults. And then they show GCB phenotype with BCL2 and positivity and strong and diffuse expression of MUM1. That's your cue. And these cases usually have a good prognosis, but definitely require immunochemotherapy. Then the next bonus case is a right axillary lymph node excision from a 59-year-old male. This is a recent case I got. And here again, there is a diffuse infiltrative large cells. There is pleomorphism. They are CD20 positive, BCL6 positive, MUM1 positive. They were CD10 negative. And CD21 shows again a little bit of disruption, but there are FDC meshworks throughout the lesion. So here, what's your diagnosis? Is it a high-grade follicular lymphoma, diffuse large B-cell lymphoma, non-germinal center B-cell type, primary mediastinal large B-cell lymphoma, or large B-cell lymphoma with IRF4 gene rearrangement? Please have the poll, please. I think we can stop the poll. I think half of the people, yeah. So most of the people called it diffuse large B-cell lymphoma, non-germinal center B-cell type, but a small percentage of you got it right. It is a large B-cell lymphoma with IRF4 rearrangement. So the thing is, there are, this is an adult, this was a diffuse pattern, but there are some clues to this diagnosis, or at least consider this diagnosis in this, that diffuse strong mum positivity in a case expressing BCL6 and the retained FDC meshworks. Diffuse large B-cell lymphoma, like we saw, should not retain. That is the criteria, right? It is diffuse. Maybe, if it is partially infiltrating and retained normal germinal centers are there, then you will see diffuse large B-cell lymphoma with some FDC meshworks. Otherwise, it is diffuse. It replaces the lymph node. And here, what I wanted to show you is this specific entity, this new provisional entity is not only in young people, and it is not always that expansile follicles. It can show diffuse effacement of the lymph node architecture. There is a recent case series in Pathology International. They report 13 cases of IRF4 rearrangement lymphomas, of which 10 patients are over 30 years of age. And the specific IRF4 rearrangement can be seen in a group of low-grade B-cell lymphoma as well. These cases show the low-grade B-cell lymphoma with IRF4 show a diffuse effacement of lymph node architecture and contain predominantly small B cells with scattered prolymphocytes or para-immunoblast-like cells. So let's move on to the next case. This is a pleural mass excision from a 78-year-old male patient who is a retired physician. This patient himself is a physician, and the patient has a recent past history of diffuse large B-cell lymphoma and received treatment for that, but the disease progressed. And there is a diffuse, here, look at this, a diffuse proliferation of large atypical cells with a lot of cytoplasm and very pleomorphic, eccentrically placed nuclei, most of them with prominent nucleoli. Some cells even show here HRS-like morphology. Some cells even show morphology, which is that classic hallmark appearance, right? So this is a very pleomorphic, anaplastic looking cells. And I will let you interpret these CD45, ALK1, and CD31 stains. And let me list out these stains for you. These stains were negative: CD30, CD2, CD3, 4, 5, 7, 8, 43, 15, CD21 and 23, PAX5, CD79A, CD1A, CD34, 56, 68, 138, cytotoxic markers, Mumman, Eberish, all of them were negative. Can we get the poll, please? The third one. What's your diagnosis here? Is it an ALK positive large B-cell lymphoma? Is it diffuse large B-cell lymphoma, non-germinal center B cell type? Is it an ALK positive anaplastic large cell lymphoma? Is it a non-hematophytic? I think we can stop the poll now. Very good differential diagnosis, ALK positive large B-cell lymphoma. Everybody thought that and that is what we need to think, particularly with that morphology and the history of diffuse large B-cell lymphoma. But a very good number of you picked it out just with that very limited information I gave you. Very good. And I did IGH and PCR, right, for clonality, and both came back negative. T and B were polyclonal. Fish was positive for ALK gene rearrangement. We did a lot of stains, and it was an epithelioid angiosarcoma. So this is what I was saying. Always keep non-lymphoid malignancies in your mind when we see things which resemble aggressive lymphomas, but not adding up with the stains. So to give you some key points to take home, and we can conclude this session. These entities under the broad umbrella of aggressive B-cell lymphoma can show varying and overlapping morphology and immunophenotype. We as diagnosticians need to provide the treating physicians with information enough to prognosticate and treat the patient. When we see an aggressive B-cell lymphoma, remember to look for areas of low-grade lymphomas. I didn't mention it in the talk, but always remember that and make accurate diagnosis of transformations. Consider non-lymphoid neoplasms when features do not add up. Make sure the stains are positive or negative in the actual lesional cells and not in the background inflammatory cells, because like in epithelioid angiosarcoma we saw, should not interpret CD45 positive when they are actually positive in the background cells. The immunostains and FISH can be done in steps. An initial panel need a pan B-cell marker and T-cell markers along with markers for the cell of origin classification, MIC and Ki67. This is the recommended first initial panel for an aggressive B-cell lymphoma. And finally, watch out for changes in terminology and classification in the upcoming next WHO edition. Thank you for all your for your attention, and I'll be happy to answer any questions you may have if I can.
So I'll read out the questions. The first one, can you hear? Can you hear me?
Yeah, Mary, you can read out the question.
Yeah. So one question, Jaya, is how would you approach a 12-year-old child with high-grade lymphoma, which is 20 positive, 10 negative, BCL2 positive, BCL6 negative, and Ki67 95%, and TDT and 34 negative?
It was 10 negative, so that's the issue, right? And BCL2 positive. So
yes.
This one sounds like a if the architecture was diffuse, it sounds like a diffuse large B-cell lymphoma. But being a child, I would do FISH first and make sure it is not a weird Burkitt, for example, or and we need to make sure it's not a double hit lymphoma. So we need to further work it up. And it definitely sounds like an aggressive B-cell lymphoma. We definitely need to subclassify, and for that, we need more studies. With that information, I don't think we can subclassify it. Yeah.
The other question was, in the bonus case 2, what was the CD10 status? That was the adult Mammon rearranged.
CD10 was negative.
There are some other questions which you have answered, I think. One question is, do you do EBER for all your large B-cell lymphomas?
Yes, EBER is like the first, it is a part of our first aggressive B-cell panel, like the first set of stains include EBER, yes.
And molecular workup also, do you do for every DLBL?
Every aggressive B-cell lymphoma get the NHL panel, BCL6, BCL2, MIC. That's the only. If we need further only, we do other molecular or genetic analysis. Yes.
Yeah, there are more questions. What is your experience with TDT negative BALL?
So TDT, I have seen a few of those, and I think the most of them are in those, like, you know, the ones which are slightly intermediate stage hematogones, right? Which are coming, the CD20 positive, surface immunoglobulin positive stage of B-cell maturation. That is where they are coming from. I've seen a few of those, and if they are presenting in a lymph node or in a, if their morphology is kind of here and there, they can be very confusing with the high-grade B-cell lymphoma. So things we need to keep in mind is put everything together, like if they are presenting in the marrow versus an isolated mediastinal lymph node or something, look for CD20 and surface immunoglobulin light chain and the markers of immaturity like CD34 and CD10, all those stains. Put the immunohistochemical and flow cytometric features together and try to put it in one category, and definitely do molecular analysis. So the molecular features like double hit or the certain genetic changes, MICRIA, those things will also lead us to a more definitive diagnosis. Most of the time we can reach a diagnosis. This is where that TDT negative ALL and TDT expression, but generally when large high-grade B-cell lymphoma express TDT, they are not diffuse and strong like in lymphoblastic lymphomas. They are kind of variable in mature B-cell neoplasms, but they can be. So this is where that caveat becomes important.
What is your experience with CK positive plasmacytic neoplasms?
Yeah, so CK and because CD138 is, we all know it is expressed in epithelial cells as well. Some of them, but it is a very rare, a very small subgroup of plasmacytic neoplasms can have CK as well. But you know, when you make a diagnosis of plasmablastic or plasma cell neoplasms, the immunoglobulin is your friend. If it is expressing immunoglobulin, then you know. And also there are other markers. And then here again, CD56 and all will become a confusing thing, right? Like neuroendocrine tumors will come into differential diagnosis if you have CD56 and CK positivity. Then do molecular, like PCR for IGH gene rearrangement. If it comes back clonal, you know it is. And also history, right? History, general clinical presentation. There are like other features which we can rely on. Yeah.
Have you seen c-MYC positivity in B lymphoblastic leukemia by IHC?
Yes. Actually, ALLs can have MYC rearrangement and MYC positivity. So MYC expression or MYC rearrangement is not a differentiating feature between the two. Yeah, MYC can be there.
Okay. Why did we get ALK positivity in the last case as a question? Angiosarcoma.
So that why I don't know. But the thing is, like in other somatic malignancies where ALK rearrangement is described, right? Like the lung cancer, they are the characteristic ALK rearranged tumors. But some somatic malignancy has ALK. That's what we need to think about. And when I had this case, I actually did not diagnose this myself. I went and showed it to, because the clonality came back negative. I showed it to our soft tissue director, who is Dr. Paul Wakely. He's very experienced and very well known in soft tissue tumors. And when I showed him, he has seen a few years ago epithelioid angiosarcoma with ALK positivity and ALK rearrangement. And that's how we ended up diagnosing that case. So that happens. But why, I don't know.
What are the pointers for IRF4 rearrangement except BCL6 and MUM1 co-expression? Is there any other pointer?
So when it was described, like when Dr. Salavaria and their group described this entity, the pointers were actually the clinical presentation, right? The first thing was children and young adults, Walder ring or head and neck area involvement, and that the very character, when you see that lymphoma, right, has a very character. It's I don't like using the word cute or beautiful to describe a horrible malignant tumor, but they have this very monotonous, expansile follicles and very large cells, but not extremely pleomorphic, ugly-looking cells, and they have retained follicular dendritic cell meshworks and the BCL6 and MUM1 stain. So these were the pointing factors. Then, because it's a child and it is not like pediatric follicular type lymphoma, and or it is not normal lymph node, we need to think about this and do the IRF4 gene rearrangement. But now that we know this can happen in adults as well, and there are different morphologic patterns, in this particular case, the one I showed you, I thought about it. I can give you that. I thought about it because it was a diffuse morphology. When you look at it under microscope, it was diffuse. But those cells were, like, again, those round kind, they were large and ugly, but kind of a monotonous pattern. And that very diffuse, strong MUM1 positivity with BCL6. And I was like 99% sure it is that because of the retained follicular dendritic cell meshworks. They were not the remaining ones of normal germinal centers. They were disrupted abnormal follicular dendritic cell meshworks within the tumor. So that's when I was like, we need to get IR4 done.
Just one more question. What about cyclin D1 positive DLBA? Maybe how to differentiate it from cyclin, mantle, maybe Cleomorphic mantle.
Yeah, there is a subgroup. It's kind of a, I would do SOX11. SOX11 is kind of more specific for mantle cell lymphoma. And then if we are going more into detail, we can do genetic analysis and things like that. But yeah, that's a diagnostic caveat. The DLB cells expressing cyclin D1. Yeah.
I think I'll give you one more question. Is FISH always done in a straightforward case of Burkitt lymphoma?
Yes, that is because a straightforward Burkitt lymphoma could be high-grade B-cell by morphology and immunophenotype could be a high-grade B-cell lymphoma, NOS or double hit, triple hit. So MIC is always done, yes.
I think that's it, Lakshmi. Thank you so much for that very informative talk with full of practical tips. Thanks so much.
Thank you all, yeah.
Thank you, madam, for that wonderful talk. So we move on to our next session, for which I again request Dr. Geeta Vidyadharan, Associate Professor Pathology, Amrita Institute, to introduce our next moderator.
Thank you, Dr. Amrita. Extending hearty welcome to our next moderator, Dr. Indu Nair, who is presently Professor of Pathology at Amrita Institute of Medical Sciences. Madam did her MD from Government Medical College, Trivandrum. She's a seasoned pathologist who's got good academic working experience at Government Medical Colleges, Trivandrum, as well as IAPM and also RCC Trivandrum. She's undergone honorary observership in her interest area, lymphoma, from the prestigious Imperial College London. Other areas of interest include gynec and cardiac transplant pathology. She's an ardent researcher as well, with many research projects on ovarian, endometrial, as well as lymphoma cases, and has got more than 20 international publications in the latest years. Welcome, madam.
Thank you, Dr. Geeta, for that introduction. And I'm glad to welcome Dr. Girish Venkataraman, Associate Professor, Department of Pathology, University of Chicago, for the next talk. An alumni of Kilpauk Medical College, Chennai, and PGI Chandigarh. He did his residency in Loyola University and a hematopath fellowship in NCI Bethesda. He has over 69 peer-reviewed publications, mostly on lymphomas. And he has written invited reviews on Hodgkin's lymphomas and high-grade B-cell lymphomas. He has co-authored and co-edited more than 10 book chapters. Welcome, sir. A young adult lymph node biopsy, RS-like cell, a combination which gives or which has given nightmare to most of us at some point of time. Well, let us hear from the expert how to tackle it better next time we encounter it. Welcome, sir.
Thank you, Dr. Nair. Thank you so much. That was a really nice poetic way to talk about a problem that we all face. So with that said, let me go ahead and pull up my PowerPoint. Okay, so my screen is on, right?
Yes, sir.
Yes.
Okay, thank you, Amrita. So, okay, today we are going to discuss a topic that is very near and dear to all of us, Hodgkin lymphoma. And so we will start all the way with Thomas Hodgkin, talk about PD-L1. And I will tell you that much of this talk is not going to be the average tutorial for you. We heard some excellent descriptions on reactive entities from Dr. Menon, and we heard excellent descriptions of all large cell proliferations and how to approach large cell proliferations from Dr. Jaya. And now we are going to focus on Hodgkin and Hodgkin type proliferations today. With that said, let's move on to the first slide and the structure of what we will talk today. Okay. So the big question I faced when I was tasked with having to talk about Hodgkin is the first question. What can someone really learn about Hodgkin lymphoma in 2021? We all know about it. We've been knowing about it for almost, 25 years. And honestly, if I show you slides of Hodgkin, it will take me 10 minutes to rattle out the morphology and the 5 stains that we all do. And I could be done in 5 minutes and my lecture here. And even those 5 stains that I'll show you are honestly not necessary to make a diagnosis of Hodgkin lymphoma. And we know that even on a touch preparation, we can easily make the diagnosis and feel good about it. So with that said, what can I really bring here that people cannot just look on the internet or find in the textbook? With that said, I will tell you that there's always something to be learned in every case that you see. It doesn't matter. If it's a super simple case, you can sit and focus and see how they actually treated the patient and what upfront treatment options they used in the patient. And if it's a complex case, you should make sure that your peers around you agree with your own diagnosis. And you should also think of the implications for therapy with a mixed diagnosis. If you make a wrong diagnosis, what is the impact? And what are the implications with persistent relapse? So this is a situation where the patient will keep relapsing and the clinicians will come back and doubt your diagnosis. How do you handle conversations like that? So most of my talk is going to be focused for the attending pathologist who receives day-to-day Hodgkin lymphoma type cases and deals with clinicians and disagreements. So with that said, I will have some poll questions here and there, but in the middle of my talk, I will randomly show slides and ask you for straight questions that I hope you will put directly in the chat. The first correct answer, I'll call out your name and you get your fame in that minute. So that's how it's going to work today. So with that, these are our learning objectives. We'll talk about Hodgkin pathology, your standard tutorial type stuff for 10 minutes. For PG trainees, I will talk about stains and how the quality of stains are relevant and important for you, and how to interpret stains. And then we will move on to illustrative cases that expand the spectrum beyond Hodgkin lymphoma. Talk about it for about 20 minutes. And I will not focus too long on the reactive entities because Dr. Menon has already covered a lot of things, but I will focus on entities where there is a tendency to overcall Hodgkin lymphoma in some settings. And then one different thing that I will be doing is I will show you my top lines of final diagnosis for Hodgkin cases, showing the spectrum of final diagnosis lines that I have come across and put across in the past 15 years or so that I've been seeing these, and some that I've learned from Dr. Jaffe that I've learned uniquely from her. And so hopefully you will see some of those digested in here. Yeah, and the workup for Hodgkin in different settings. So with that, let's go back 200 years when Sir Thomas Hodgkin described the original cases of Hodgkin. He had like 6 cases, Hodgkin, in that time. And honestly, I think only about half of them were really Hodgkin lymphoma by the current standards. And all the others turned out to be something else, maybe a T-cell lymphoma or something. That's what Dr. Poston said in a commentary a few years ago. That doesn't diminish Hodgkin's contributions. But anyway, we need to remember that between 1899 and 1902, Dorothy Reed and Carl Sternberg, this guy is in Germany, and Dorothy Reed is from Hopkins. They both saw these cells, this lymphoma, and they described the cells. So the cell of interest has all these 3 people's names, Hodgkin, Reed, and Sternberg. Yeah. So as time came by, in the late 90s, the real classification came. There was a lot of drama around Hodgkin in that time when the German people studied a whole bunch of cases and they separated out nodulolymphocyte Hodgkin as a distinct entity. And when all that happened, microdissection studies and things like that got very good. And by early 2000s, we had kind of perfected the art of microdissecting cells from sections. Yeah. And so early 2000s to 2005, we learned a lot more about PMBL, gray zone lymphoma, that showed up in the WHO too, as you know. And now we have come a long way, and now we talk about all these T-cell lymphomas, which have Hodgkin-like cells. So now we will navigate through some of these and dissect the settings where we work up the cases slightly differently. Yeah. And of course, this is a classic picture of the Hodgkin-Reed-Sternberg cells. And this is Dorothy Reed Mendenhall, an excellent physician from Hopkins. So Hodgkin originally described cells that were mononuclear, like these guys. Whereas Dorothy Reed and Carl Sternberg described kind of cells that are multinucleate. So the classic binucleate owl eye, that credit goes to Reed and Sternberg. So when you describe the cells in biopsies, you would describe them as mononuclear Hodgkin cells or multinucleate Reed-Sternberg cells. That's one soft pointer when you write reports. So it makes it clear what you know. So with that said, let's step back into the basic biology of the B cell, starting from the bones to the B zones. So you have the B lymphoid blast that develops from the bone marrow. And that's why you have the B lymphoblastic leukemia. This develops into the mature naive B cell, which again evolves. And tumors that arise from that include the CLL/SLL. This is a very simplistic way of talking about CLL. Honestly, I shouldn't make it so simplistic. But anyway, this serves for practical purposes. And the next is these cells finally go and settle in the lymph node in the follicles. And you have the primary follicle or the mantle zone of the secondary follicle, from which you have mantle cell lymphoma. And then you have the germinal center, from which there's a whole host of lymphomas that arise: follicular, diffuse large B cell, Burkitt. And then, of course, the post-germinal center marginal zone has a marginal zone lymphoma. And then the plasma cell is the source of myeloma. But mind you, myeloma does not arise from nodal plasma cells. Rather, myeloma arises from long-lived plasma cells in the bone marrow. So even though biology tells you that plasma cells develop here, the source of myeloma is long-lived plasma cells. So that's just one trivia that you should know. But anyway, the focus today is Hodgkin. And I'll tell you that the flavors of Hodgkin arise from the germinal center. So when it comes to subtyping lymphomas, it's a very easy rule that we all follow. So if there are a few scattered, funny-looking large cells, then we try to box it into one of two Hodgkin lymphoma subtypes. And if it's numerous lymphoma cells, and the key part is knowing that the numerous cells you see are actually lymphoma cells. That becomes very tricky sometimes. So remember that. We choose one of the gazillion non-Hodgkin lymphoma subtypes. Yeah. So now we don't need to go through that big laundry list. We will stop with classical Hodgkin and talk about Hodgkin itself. So this is a classification that's been there for 25 years. I don't need to describe this classification to you. Classical, and then there is nodal lymphocyte predominant Hodgkin that used to be called lymphocyte predominant Hodgkin disease in the past. Then the disease became lymphoma the moment they knew that they are B cells. And the word lymphoma has stuck. So nobody should call Hodgkin disease. So now the classical has these four flavors. And of course, we all know that nodular sclerosis is much more common in the West, and it occurs in the mediastinum, and it has less association with EBV. And mixolarity is probably more common in India, which is what I saw frequently with granulomas. It is frequently EBV driven. And of course, we have the lymphocyte depleted, which I may have seen like two cases, one in my fellowship and one very recently. And again, this is usually EBV driven, and it's and often occurs in the setting of HIV and immunosuppression. So that's your lymphocyte depleted Hodgkin's. And of course, the lymphocyte rich throws a big wrinkle and kind of overlaps this entity called nodular LP. So that was the subject of the late 90s, where they kind of confused lymphocyte rich with nodular LP and tried to separate down in the German Hodgkin study group. Yeah, there were some major publications that came at that time. I can give you references later if you want. So with that said, let's get back into the few malignant cell situation. And Teresa Marafiotti described these cells and proved that they are indeed B cells. She did some really elegant studies back then. So your classic Reed-Sternberg cell looks like this, with the owl-eye nucleoli, thick nuclear membrane, and it has the phenotype 30 and 15 without any CD20. Yeah, that's the Hodgkin Reed-Sternberg cell. Yeah, technically Reed-Sternberg. And this is the nodular LP cell, which looks like a potato with few dots inside of it, and like a potato going bad, I should say. And that is 30 and 15 negative and 20 positive. Yeah, just 3 markers are pretty much necessary to make the call. And these cells are called LNH cells, or lymphocytic and histiocytic cells, or you can call them lymphocyte predominant cells, or you can call them popcorn cells because they look like popcorn kernels, but they're not called Hodgkin cells. So none of the cases that Hodgkin described were really these entities. Yeah, frequently I see medical students calling these as Hodgkin cells of NLP. In reality, you shouldn't call it like that. So with that said, let's move on to some phenotypes. Yeah. So here I'm showing you 4 pictures. I put some nice labels on them. And now I'll tell you that something is wrong in this slide. And I'm really hoping we can get to finding out what's wrong in this slide. Can you pull up that poll question 1? Let's see, and have you guys do the poll. It's not really hard, but I'm sure just to find out that you're all awake. And hopefully only students do it, and senior people don't need to take this test because I'm pretty sure they all know. Trainees are the best. Okay, how far have we gone? Okay, let's close the poll. Okay, do we see the results? Okay, see, good. Half of you said that the last stain is the wrong slide. So I am very happy that at least half of you said. I would really have wanted 90% of you to be able to pick on that. But anybody want me to tell me what that last stain really is? Go ahead, do it in the chat if you can. And the first one gets the credit. Okay, Imran says PAX5. Good thought. That's a closest differential, but this was not PAX5. Okay, give me one more choice. Quick. CD30, EBV, no. Those are all very far away, those answers. Next, keep going. There's so many of you. OCT2, Ayman, you win. Yeah, so it is OCT2. So this is actually not the LP that I'm showing you with an expanded. This is called expansile mottled lymphoid proliferation. So be very creative with your descriptions when you describe lymphoma. At low power, when you see this expansile mottled look, you know right away that this is not an LP. This is one thing that Dr. Jaffe trained all of us to do. I'm sure Karthik and Jaya would vouch for it, that you do the 4X, you look at it, yeah, this smells like nodular LP. And of course, you go at high power, you see the funky cells, and of course, you see the CD20. The key thing is not only are the cells positive for CD20, but you see this. So you see this rosette of CD20 negative cells, which are your T cells that are rosetting the cells. And so this kind of phenomenon is very easy to see. And of course, this was OCT2, like Ayman said. And for some reason, OCT2 is a much better stain to pick out LP cells compared to PAX5 or any other nuclear marker you do. So it's hands down the best marker, I think. You don't need much else to make the diagnosis. Yeah. So let's keep going. And this is your classic nodular LP, and it is rich in histiocytes. And the LP cells tend to keep company of histiocytes, almost like they need that armor of histiocytes that are inactive to protect them from immune surveillance by the lymphoid tissue. So that's why they are called lymphocytic and histiocytic cell. Yeah. And if you note the CD20 on the right side, you can see that the large cells seem to always linger around a nodule of what looks like small B cells. So this association and pattern became very important to know, because most nodular LPs show this kind of a close association, and we call this an immunoarchitectural pattern of large cells associated with the small B cell nodules. So speaking of this pattern, a group in Stanford identified a bunch of patterns in what looked like nodal LP. And they came up with a bunch of patterns. And so after that association, they looked at several nodal LPs in Stanford and came up with 6 different patterns of this architecture business. And so here are the typical patterns they saw, where the tumor is rich in small B cells, and the large LP cells have association with the small B cells. So you have a nodular pattern of small B cells with large cells inside of it. And then they talked about serpiginous nodules, where the nodules become looking like serpents. Yeah. And then you have the moth-eaten B cell rich pattern on the right side. And all of these are your typical patterns that you see. And Fan et al. Described this paper. And this is a paper that we keep citing again and again in Dr. Jaffe's consults all the time. And then they describe patterns that are not typical of usual nodal LP. And for the record, the case that I showed you just now was a B cell rich nodular pattern. Yeah, pattern A. So when you write your reports, if you can put this pattern business into your top line, it shows that you know that much more about nodal LP. Yeah, and then they describe these variant patterns where the lymph node was very rich in T cells. So you start out by nodules that are rich in T cells, which is not the normal case. And these cells become very unhappy. The LP cells become very unhappy when T cells come inside the follicles. And so when T cells are there, the LP cells don't like to mix. Yeah, they were like Saas and Bahu. They like to get out and run away when these green guys come inside, which are the T cells. Yeah, when the green T's are in, the cells come outside and at the edge. So that's called pattern C. And then at some point, there are so many T cells that coalesce totally, and it just becomes a sea of T cells with scattered large cells. And this pretty much looks like your T cell rich large B cell lymphoma that Dr. Jaya showed us. Yeah. So this was very nice and elegant patterns that they showed. And this was followed up by studies from the German Hodgkin study group. Yeah. Because the Germans are really good at keeping all their cases together in a registry, and they come out with really massive numbers and wonderful follow-up. So that's why they are able to publish cases with 1,000 cases and 2,000 cases of nodal LP, whereas things are disjointed everywhere else in the world. So they came out and said that this variant pattern nodal LPs tend to relapse more often. I'm not sure that these patients fare poorly in terms of overall outcomes, but they relapse sooner, and the morbidity is more if you have a variant pattern. And so Sylvia Hartman showed that in like 2013 or 14, something like that. Yeah. And with that said, where are we? Okay, what am I showing you right now? Anybody on the chat? What, OCT2? No. What is this H&E showing? What's the diagnosis? You all should know. Nodular sclerosis, Hodgkin, good, Sankappa. So this is very easy, right? So it's low power, expansile proliferation with dissecting bands of fibrosis, and there's this moth-eaten appearance, and Shira is also confirming that it is nodular sclerosis. And these are your lacunar cells, and these lacunae are formed because of formalin fixation. It's an artifact, we know that. And the background is usually full of eosinophils, histiocytes, plasma cells, even neutrophils. So this is your typical classical Hodgkin lymphoma, the textbook picture. And this exact same case that I took is in the ASH image bank. So if you find really good cases that are typical, think to submit to the ASH image bank. And this is your lacunar cell at high power, and this is a mononuclear Hodgkin cell. Yeah, so this is easy enough. And that is your multinucleate Reed-Sternberg cell over there. So with that said, I guess we can discuss some stains. Yeah. And yet again, I have put 3 stains for you, A, B, and C. Okay, let's bring up the poll. So read the question and choose the right answer. It's a little tricky, but I'm hoping at least 50% of you get it. That's my hope. Yeah, anybody less than 50%, you have all failed in Hodgkin's. Okay, time to close the poll. Okay. All the above nonsense. Okay. Sadly, no. So this is a double question actually, and I'm sorry I made it tricky for you guys. Less than a quarter of you got the right answer. So the true answer is what? Anybody want to say? Attendings, maybe. You can send it in the chat, senior people. Or maybe I can call out from the panelists. Okay, nobody's answering anything. Never mind. Okay, Fernando, yes, you get the credit. This is indeed L26. Okay, my wife is calling. I can't do that. Okay, so yes, Shamir, you're also right. Panel A is the correct answer. That is actually L26, which is the clone for CD20. So this was a lesson for all of you that didn't know that the word L26 corresponds to the clone of CD20. And of course, you have to know that in classical Hodgkin lymphoma, the normal small B cells will stain for CD20, but the Hodgkin cells usually don't express CD20, even though it's a B cell lymphoma. Yeah. So this is your Hodgkin cells, negative for CD20 with background small B cells on CD20. And this is not ER. Yeah. And this is going to be PAX5. Yeah. And this is PAX5 staining weak in classical Hodgkin lymphoma. And you have the small B cells that are staining strong in classical Hodgkin lymphoma. So make sure that your internal controls are always good. Your internal control for PAX5 is your background small B cells. So pay attention to that. Nuclear stains often don't work too well. They are very finicky, especially if you use a low pH retrieval protocol. You have to use a high pH protocol for all nuclear stains. This is a very easy rule that you can follow. And of course, this is not nonsense. This is your stain of interest, CD30 in classical Hodgkin lymphoma. The other name for CD30 is TNFR SF14. Yeah, so that's important to remember. Okay. Okay, with that said, let's keep going. Okay, question 2 we finished. Okay, next, EBER. Okay, so inside to hybridization for EBV. Let's talk a few points about EBV-ish. So this is RNA inside to hybridization. This is not the same as IHC. What you're looking for is EBV RNA, and we are testing a probe for the RNA. And this is a much better marker than EBV LMP1 because EBER-ish is sensitive across all the latency phases of the virus. So in Hodgkin lymphoma, you're going to have only one latency phase. Yeah. So like in PTLD, it's going to be a different latency phase. So you can't be chasing with EBV specific proteins for every single case. So EBER is great, but it's 6 times more expensive, at least in the US from what I do. And I'm sure it's the same or even more back there. And EBER is finicky about how well the tissue is fixed. So that's a caveat with EBER. So that's why if you think it's Hodgkin and your prevalence is higher, you may be better off using LMP1, although sensitivity is low. When you do EBER-ish, you will have to do one extra slide that makes sure that your tissue of interest has good RNA. So that's why they do a control called the U6 control, which is the uridine 6, which tags the poly A tail of the RNA. So all RNA has the poly A tail. So the U6 control will help you know that your tissue is actually good quality and fixed well with good RNA. So that way you will believe a negative case when it's truly negative. So next, this is one pattern that I learned in my fellowship. So this cell that you see is a Hodgkin cell. And I'll tell you, this is a marrow involved by Hodgkin lymphoma in a HIV patient. And a HIV Hodgkin often is EBV positive. And this is the pattern called the Hodgkin lymphoma pattern of EBV, where the EBV is restricted only to the Hodgkin cells. Yeah. And this here is large cells and some small cells positive for EBV. Yeah, so that is a non-CHL pattern of EBV, which you see in a whole host of EBV entities. It could be EBV reactivation, it could be AITL, it could be other EBV mucocutaneous ulcer that was described recently. So this is one pattern that you should look for when you look at the EBER stain. Yeah. So at the end of the day, we know that Hodgkin lymphoma lacks B cell markers. So, and yet this is a B cell lymphoma. Yeah. This was well described by studies by Foss et al. Back in Blood in 1999, when the early days of microdissection had come through. So once we know about Hodgkin, so people slowly recognize that there are some Hodgkin cases that seem to have more Hodgkin cells than you normally see. So people recognize that Hodgkin usually has the milieu of mixed inflammation that you see in Hodgkin. And they recognize that Hodgkin has a phenotype that shows decreased 20, expressing 30. And I call that as the typical Hodgkin pattern of immunostaining. And by M, I mean microenvironment of Hodgkin. So the typical Hodgkin lymphoma would have the IHC pattern of Hodgkin lymphoma, the classical Hodgkin, and the morphology in the milieu of classical Hodgkin lymphoma. Then they recognize cases that seem to have a lot of Hodgkin cells, and they call those as grade 2 NS. And by 2000, we knew that NLP is not the same as Hodgkin, and so they described that separately. So people looked at these grade 2 cases more to see if they do any worse. So there was a bunch of studies that they did in the past, and there's a slew of studies that I'm citing here, where one said it's negative, some said it's not quite that negative. Each of these studies were designed differently in different countries. But at the end, it became clear that it's good to mention grade 2 NS regardless, because the general consensus is that they do tend to relapse sooner. And then after the early 2000s, things started getting a little tricky. And we all know that Hodgkin usually expresses weak to negative 20, and there are reasons for why the B cell program is downregulated. There is a methylation of key genes related to B cell transcription that makes it weak to negative 20. And then slowly, people started describing cases where Hodgkin cells express strong 20. And MSKCC put out a paper saying that, hey, the Hodgkins with a strong 20 tend to do worse. So that's a Kaplan-Meier plot showing the same thing. So now, with these studies, we saw that there was Hodgkin lymphoma that was classical, and there was a strong 20 positive Hodgkin lymphoma, which kind of muddies the picture. And this was a study published in 2004 by Christina Portlock, and they describe these cases. So I'll tell you, by this time, there were some entities that we did not really know about. So this is understandable in this current day and age. So now we know about classical Hodgkin, then the one with lots of Hodgkin cells, the NS2. And then we learned about the Hodgkin with strong 20 that they described in 2004. And as we go to the right, the 30 keeps going down and the 20 keeps going up. So you see the top and bottom there. And at the other extreme, we have diffuse large B-cell lymphoma, which has the morphology of DLBCL with sheets of cells and the IHC of large cell lymphoma. So now this is your classic PMBL. So I'm not going to describe PMBL to you. Dr. Jaya has done this. Nice compartmentalizing sclerosis, cells that look like they are floating in a pool of cytoplasm. And here is the phenotype, strong diffuse 20. And this is your pattern of CD23. They are often expressing 23. So that's something that's very useful. And they also express 30, but the 30 is kind of weak to moderate. It's never like a diffuse strong 30. Yeah. So these mediastinal large cell lymphomas, they cannot make immunoglobulin for some reason. This is very similar to B lymphoblasts, which make neither kappa nor lambda. And yet they express OCT2 and BOB1 and 79A. The B cell program is preserved in these cells though. So if you do flow in a mediastinal mass and you see neither kappa nor lambda, so think mediastinal large B cell lymphoma. Yeah. With that said, there was a lot of genetic studies in PMBL, and I'm not going to get into the detail of all of this, but I will allude to a couple of things. So in PMBL and Hodgkin's, you have gains on 9p which is where you have JAK2. So the JAK-STAT pathway goes very active in that disease. And also PDL1 and PDL2 are also sitting on 9P. So 9P is a very hotbed for a lot of things. And of course, there's a lot of genetics like the class 2 transactivator breaks in both these diseases that tell you that they are somehow brothers of each other, PMBL and CHL. And of course, there's increased PDL1 and it suppresses the immune response. So that's very typical of PMBL. And Dr. Jaya said about how PDL1 is expressed in PMBLs. So with that said, we are expanding things further. So we have DLBCL that is 20 positive without 30. Yeah. And somebody did ask about 30 positive DLBCLs earlier. I see that in the Q&A. We will get to some of that. So this is your PMBL that kind of overlaps with DLBCL. And it is 20 positive with weak 30. And then you have your Hodgkin that sits somewhere in between all of this. So there is a connection between all three. Yeah, that is Hodgkin is 30 positive, 20 negative. Yeah. So now we have all these 4 pieces that lined up here. And at some point in after 2000s, we realized that there must be cases even in between those 2 continuum there. So, excuse me. So people realized that there was a continuum going there. And studies came out in the early 2000s yet again. So let's do a case and see something because we've not seen pictures for a long time. So this is one of my fellows who is in a nearby hospital. He sent this case to me. Hey, Dr. Venkataraman, I have a case. This is a 24-year-old patient with a bump in the clavicle. She has difficulty breathing. There's a mediastinal mass. So the age, location, everything is perfect for our diagnosis. And it's a mediastinal biopsy. And then there's radiology that he sent. So I'm not an expert in radiology. The first time I see something, my mind is first thinking, is this X-ray, CT, or MRI? First, and then I'll choose, oh, okay, this is not X-ray, this is CT or MRI. So I'll tell you, there's a mass here, and you have to believe me that what I've circled is the mass there. And this is the H&E right there. And you see the H&E, and I'm sure all of you are thinking of some diagnosis, even as I put the H&E in. And this is not so much as part of the diagnosis moment here, really. And then we look at higher power. And these are outside H&Es, so bear with me for the quality. They were not too good. And this is the high power of the H&E. Nice compartmentalizing. There are funny cells. There are even some eosinophils. And we are seeing immunostains. So here I've told you what immunostains these are. And these are the correct labels, so don't worry. To CD20, and you see CD30, large funny cells. Yeah. And there is CD15 that I'm showing you, the granular staining right next to that funny cell, which looks ugly. And this is PAX5 showing weak staining, and there are strong PAX positive B cells in the background. And I'll show you even more B cell markers. Yeah, the 2 brothers, OCT2, BOB1. Yeah. So this is BOB1 is missing. The background B cells are expressing BOB1. So every time I look at a stain, I will make sure that your internal controls are working properly. This BOB1 actually is not suboptimal. That's the truth. Yeah, you shouldn't have such weak BOB in the background B cells. And this is OCT2. And you can see that these are your cells of interest, positive for OCT2. Yeah. These are weak positive cells, whereas your strong background B cells are there. Yeah. So that's your OCT2. So I've already showed you a lot of stains. So let's pull up the poll. Did I put a poll here? Yeah. So let's get a diagnosis going. Okay, I think we are getting short on time, but we will finish hopefully, or I'll cut short some of the things. Okay, close the poll. Okay, CD30 positive, B cell lymphoma. Like 45% of you have thought this is PMBL. Second set have thought it's probably gray zone. And a quarter of you did think it was classical Hodgkin lymphoma. So that was the reason, right? So the discrepancy that all of you have, and that was the reason it was sent as a consult to me. So what to call it? I will tell you that based on the weak Basal program, yeah, the 20 is negative, the OCT2 is kind of missing, Bob is missing, it's weak packs. So phenotypically, it's pretty good for Hodgkin, yeah? And honestly, you don't have a good reason to run away from Hodgkin in this case, even though there's a lot of cells, yeah? Is 15 positive too. So technically, this is not a sclerosis, and this is maybe grade 2 NS with a lot of Hodgkin cells. There's nothing immunophenotypically abnormal about the case for you to jump about. You know what? Dr. Mampilly is asking me about LCA. Honestly, I don't remember offhand if LCA was positive or not. So I can't really tell. So I think most of the markers fit with not a sclerosis Hodgkin, at least based on site, age, diagnosis, morphology, and phenotype. So the best was to stay with NS grade 2 at the time. So this is real time. And sure enough, okay, I also agreed. Yeah, it should be Hodgkin. And I put a rubber stamp on what he said. And they gave 2 cycles. And after 2 cycles, they do PET adapted therapy. That's what they call PET adapted therapy in Hodgkin. So many trials in Hodgkin, they'll do a PET after 2 or a PET after 3 cycles, and they'll evaluate the response, and they might change therapy. So that's why all trials are like that. So sure enough, they did a PET after 2, and there was a mediastinal mass. From the SUV, went from 22 to 7. SUVs of less than 10 is okay, but 22 is really high. So they saw persistent disease there. And so they gave 2 cycles of dose-escalated Biacop, okay, another acronym soup that they like to use in Europe, Biacop. In the US, people don't usually use Biacop like that, but they just used it here. And the PET showed more uptake in the mediastinum. So obviously, the clinicians are going to be suspecting about your diagnosis that you gave. Yeah, so they rebiopsied the chest wall mass yet again. So, and now they're asking, what is it now? So now this time around, this is how the biopsy looks. It's not a great H&E, but higher power should be good. So it looks, this is how it looks. It looks like what? Sheets of cells. Yeah, nothing necessarily tells me anything further. And these are your stains right here. Yeah, and there's CD20 and there is CD30. I don't know if you can see the labels. Yeah, they're up there. And this is your other stains that I have done. CD15, Ki is sky high. 15 is negative. You'll just take my word for it. And this is neutrophils in the background, negative for 15. Yeah, and this is PAX5 strong, and these are your other markers that I'm showing you. OCT2 super strong. So this is not the same phenotype. So with that, we ended up calling this a gray zone lymphoma, right? So in the ideal world, the second biopsy would actually be consistent for a large cell lymphoma expressing CD30, and you wouldn't be wrong into the diagnosis. But you do have to use your clinical setting. A young patient, mediastinal mass that looked like Hodgkin, and a few cycles later, it looks like large cell. So now this is what gray zone lymphoma is. And this is how most of your gray zone lymphoma cases will come. They are not usually the composite gray zones that you see all the time. This is your typical average gray zone that you will see time and again. And the second lymphoma that I saw can often overlap PMBL. So you can see that phenomenon too. This is your classic PMBL, gray zone lymphoma. You have sheets of cells that lacks the right microenvironment, and it might have CD20, 30, and 15 all at the same time. And this kind of phenotype is something you'll see all the time. I will ask you to go back and read the original papers from Dr. Jaffe's group on gray zone lymphoma. So, but I'm not going to sit and discuss this paper in detail right now. So they talk about sequential gray zone, where a Hodgkin and then a large cell comes. And then they talk about composite gray zone, where in the same biopsy, you see Hodgkin and large cell simultaneously in 2 different parts. Okay, so that, and these are some of the pictures from that study. And morphologically, they might look like Hodgkin or PMBL, but phenotypically, they might look like CHL. So you have all these strange combinations. This is that study. So we will skip some of these slides. And so one thing you should remember that can express isolated strong 20. So that doesn't mean you call them gray zone lymphomas just because there's a little strong 20. So everything else has to fit and the Basal program has to be strong across the board, then you can push to gray zone. And although the 20 positive Hodgkin cases, like what Portlock described, will still do badly. And whether those need to be treated like gray zone or not, we don't really know. But studies are coming and hopefully we'll know. Now, we go back to the same slide. So we know Hodgkin, we know nodular sclerosis Hodgkin, we know the 20 positive Hodgkins, we learned about the PMBL, large cell, and then we also learned about gray zone. So now all flavors of Hodgkin get treated with ABVD. The DLBCLs usually get treated with CHOP-R, yeah, but not PMBL. So that's a typo technically for me to say that PMBLs are treated with CHOP-R. And then you have the gray zones, which are typically treated with big CHOP-R, which is EPOCH-R, yeah. So that's that. So now let's do a quiz, quick quiz. So read this history, and then we will go from there. This is what I'm going to show you in the next slide. A 20-year-old male with a lump in the neck. Dr. Veena removed the node and sent it to Dr. Hemachandran, Calicut. And Dr. Hemachandran did all the right stains, but somehow the lab technician lost all the immunostain labels. Despite this, they came up with an appropriate diagnosis. And I want you to look at it and tell me the correct statement. Yeah, use your morphologic skills and make the wise choice. This is not an easy one, I'll tell you that. So don't jump to the answer quickly. So I will give you another 10 seconds because it will take a little time to process. The stain at the top right and the top bottom are the same at low and high power. That much I can tell you. Let's maybe bring up the poll. This is a very common stain. I'll tell you that much too. This is not some esoteric stain. That's really hard. Again, this is a double question of some sort. But I'm hoping at least 30% should get the answer in the poll. Okay. Okay. Okay, let's close the poll. Okay. Oh my God, you all got the answer. At least 49% of you said pattern D revealed here in the CD20 stain. Excellent. So yes, this is classic pattern D, where all the T cells have gotten inside the nodules and the LP cells are very, very unhappy. So the 20-year-old with a pattern D nodular LP. So very good, very good. CD30. Okay. If it is CD30, there can be a different answer, but we won't discuss this today. So we can discuss that offline. Excellent, excellent. I'm so happy today. Okay, now the big bandwagon of cases. So now we learned about Hodgkin with strong 20. And then we learned about large cells that overlap Hodgkins, yeah, like the gray zones. And then there is also an element of Hodgkins with strong 20 that overlaps T-cell rich large B-cell lymphoma, which can express some weak 30 sometimes. And so this distinction can sometimes become tough, the 20 positive cases versus T-rich B. And we all know that nodular LP can progress to a T-rich B. So this is a big continuum. So you really have to know where you are in the spectrum. And to add to all this confusion, you have PTCL with Hodgkin-like cells. That is a recent entity. But again, common things are common, rare things are rare. So don't jump to PTCL in every case of Hodgkin and start working it up with PCR. That's my approach. And of course, you have EBV large cell lymphomas, which can pretty much be like any of these guys. So do your EBR, make your judgment, and then decide what to call it. Yeah. So that's the honest technique. So this is my approach slide, and I'm not going to dwell too long on it in the interest of time, but I can forward you this. This is basically using CD30, 20, and 15 just to make that equation of assessing. The tumor cell rich cases, you do these stains, and then finally you can get to gray zone in multiple ways. And then tumor cell poor cases, I tend to make a diagnosis of EBV positive Hodgkin and EBV large cells and T-rich B. Generally, this is the approach I take around this gray zone, EBV large cell, and T-rich B. So this I'll forward to you guys later, but let's keep moving and try to get the rest of the content in. Now with that, let's switch gears and go to common settings that pose challenges in Hodgkin lymphoma. So time and again, a consult will come asking for second opinion, where you have cells like these in the lymph node, numerous cells. These are reactive immunoblasts versus Hodgkin cells. This is probably the most common cause for second consultation in Hodgkin lymphoma. And one most useful stain that you can do is CD15. Reactive immunoblasts will never express CD15, but interpreting CD15 can be tricky if you have lots of neutrophils. So these are your strong neutrophils inside capillaries, whereas these are your monocytes with weak CD15 over there. And because immunoblasts have the exact same phenotype as Hodgkin for CD30, MUM, 79A, Basal markers, everything is the exact same like Hodgkin cells. So be careful around these. The second setting is doing a PD1 and seeing a numerous PD1 positive cells. So people immediately think of AITL the moment they see numerous PD1s, and they immediately think AITL with Hodgkin-like cells, just because they know a rare diagnosis. At the end of the day, common things are common. CHL is more common than AITL, and don't go do a T-cell PCR just because there's a lot of PD1. I see this time and again, and of course, there are some certain flow populations that are common in AITL that you can look for by flow. This is an adjunctive thing that you can potentially do. But yes, numerous PD1s is not equals to T-cell lymphoma. And this is your classic PD1 patterns in reactive hyperplasia, where the follicular helper T cells inside reactive follicles are positive. This is a PTGC pattern where all the PD1 positive cells are increased inside the disrupted follicles. This is the reactive follicle here. This is the PTGC follicle. And this is your AITL pattern 2 that Ayoma Atigale described wonderfully, from the Isaacson group. And there is this corona of PD1s around the follicles. And these are the reactive PD1s inside the follicles with the bright PD1. That's your classic pattern 2, AITL. I don't know if you'd call it AITL, rather follicular T-cell lymphomas. And of course, I'll give you some pearls. CD15 can be positive in CMV infected cells. And they can also be positive for CD30. And I've seen cases where they've called CMV lymphadenitis as Hodgkin's. CD15 and EBV can be expressed in order LP2. So Alison Huffman has described, and I have also described with Dr. Jaffe, cases of 15 positive non-order LPs. That doesn't make things gray zone. But Hodgkin classical can never be positive for CD30. Remember that. But CD15 and PAX5 can be negative in classical Hodgkin, and you can easily make the diagnosis. The distinction between T-rich B and classical Hodgkin can be very thin sometimes. Your titration of CD20 and CD30 antibody can determine things. If you do a poor CD20 in a case, your T-rich B will be called CHL in no time. And if you do a poor CD30, you might end up calling things T-rich B. And it's a massive treatment difference if you make that mistake. We have had that happen too, where we read slides from an outside institution where we called something classical Hodgkin, and later it relapsed. The disease persisted, and then in the repeat, we did in-house stains, and we called it T-rich B. The clinician was really mad at us because he has to go have that conversation with the patient at relapse. And a misdiagnosis is not something you want with poor IHCs. So again, this patient has massive adenopathy and fevers, and there's no poll here. I'll show you these 4 stains. Tell me the right answer. Quick, we don't have much time. Okay, I'm already kind of over time, but let me. Perfect, Samriti, you got the answer. This is CMV lymphadenitis. This is not a Hodgkin cell, and this is CMV immunostain, like you said. And what is this cell that I'm pointing to? Anybody? Any students? This is a cell you should be able to recognize, and it's critical when you know to grade follicular lymphomas. Dendrite. Yep, Imran, you're right. This is a follicular dendritic cell. No, it's not an immunoblast, Chalaja. This is an FDC. It's a doublet nucleus. It's very typical of FDC. Okay. For a minute, let me ask Dr. Rajan, should I continue or should I cut short my lecture with this? I still have a few more slides. You tell me how much you want to keep the timing.
I think you can continue for another 10 minutes.
Okay, fine. Thanks, guys. So with that, this is my typical workup for Hodgkin. I usually do all formalin. I tend to be a minimalist. Mostly I don't do flow or cytogenetics. And my colleagues hate me here for it. And that's just me. Rarely I will freeze a portion for research. And I'm generally telling that people should be wary of calling things boldly on cytology. All my cytologists have fights with me because I'm not calling Hodgkin on cytology. I've had at least one patient where the chemotherapy port was removed once the biopsy came back. The cytologist made a call of Hodgkin on a touch prep, and they called it, they told the clinicians, and then the biopsy came back, they were reactive immunoblasts. Yeah, so you have to be careful. And the standard IHC panel is CD20, 3, PAX, 30, 15, EBER. That's my initial panel. If it is rich in a lot of tumor cells, and if it's 20 strong, which happens often at relapse, then I will add extra basal markers like OCT2, BOB1, like the case we saw for the gray zone. And of course, EBV large cell can also be missed. Post-therapy, when they look at fibrotic tissues with rare possible Hodgkin cells, I like to do MUM1 and CD30. They are the most sensitive stains. They're the best stains to pick rare cells in a sea of fibrosis. So with that, we come to the last parts where we have a situation where people disagree with the diagnosis. And the first instinct is, how dare they disagree? I have 20 years of experience. The second question is, you probably know that you are wrong, and you think to yourself, what do I do? And then you ask yourself, who is right? And the fourth question that goes in your mind, will I be sued? So these are questions that keep coming all the time, but these will be less important to you the moment you look at the buckets of diagnosis and how they are treated typically in this setting. So typically, T-rich B, EBV large cell, EBV gray zone lymphoma, that the French people call it as, an advanced stage and LLPHL get treated with CHOP-R. You use EPOCH-R for PMBL and gray zone lymphoma. This is a big daddy of CHOP-R. For CHL, it's ABVD or a square VD, which is Adcetris or brentuximab with, and then you have Biacop, which the Germans use. For PTCLs or AITL, treatment is usually CHOP, BCHP, which is brentuximab, which has become popular these days, or COP if patients have cardiac failure. Yeah, they remove the anthracycline. So now these buckets of diagnosis are less rigid when salvage and auto is the next option. Basically, they are wiping the whole thing clean and they're going to transplant with auto. So when you're thinking between T-rich B versus EBV positive lymphoma, it's not much of a distinction. You don't need to break your head over T-rich B versus EBV large cell most of the time. Yeah, so that's one thing to remember. So here are some situations I've learned along the way, and this is for all consultants. So after transplant, you will see PET active nodes that often are related to immunoblastic proliferation in the setting of immune reconstitution. That frequently happens after transplant, and it's not lymphoma, and that's perfectly okay. And I can send you some references for that. PDL1 has no diagnostic value in CHL diagnosis. For PMBL, perhaps yes, it is diffusely positive, but testing is not mandatory. Yeah, if somebody keeps asking you, you have to do PDL1 for Hodgkin, say no. And numerous PD1 cells doesn't mean T-cell lymphoma. And so don't do PCR on everything that looks and fits CHL otherwise. And when Hodgkin is relapse, test the B-cell program, yeah, and make sure that it's not become gray zone. So there are some sample format write-ups that I'll show you, and you can use some of these if you encounter cases. So this is a sample write-up for me, where I'll say relapsed classical Hodgkin, grade 1, expressing strong 20. So usually I'll say words like these, they express a strong 20. And I'll explain why I think it's still Hodgkin and not grade 1. Yeah. So despite strong 20, there's downregulation of X and Y, and there's negative EBER, and this supposed designation as CHL rather than grade 1. So it's good to put a comment like this when you say something odd. This patient was ultimately treated with salvage and auto in the relapse. So it didn't matter whether I called it Hodgkin or grade 1, honestly. These are other samples where I have a grade 2 nodular sclerosis with aberrant T cell antigen expression. Sometimes you will see T cell antigens even in Hodgkin lymphoma, and that doesn't mean it's a T cell lymphoma. And this happens often in nodular sclerosis cases. Yeah, and no need to do T cell PCR. And some more here where there's a 55-year-old male who has had IBD, and he was on infliximab, and he developed a Hodgkin-like proliferation at the site of the stoma. So this is an iatrogenic immunodeficiency-associated LPD, and phenotypically, it looks exactly like Hodgkin lymphoma. So never call directly as Hodgkin lymphoma in such settings, because they can just treat with reduction of immunosuppression, and or they can give rituximab for that matter to get rid of the EBV. And this is one typical one that I use, dense fibrosis with rare MUM-positive large cells, suspicious but not definitive for relapsed Hodgkin's. Yeah. And this is the best stain if in treated disease. It's not specific though, but in this context, it totally works. And this is more in a young 20-year-old patient, a pitfall that you should remember. Atypical EBV positive lymphoproliferation of indeterminate potential in the setting of primary infection. Normally, people don't biopsy nodes in primary infection. And usually I will go and see the peripheral blood to see if there's mononucleosis. And I will ask them to do a monospot test to check the EBV serology. And if this is a resolving primary infection, I will ask them to wait and watch, because some primary can progress to lymphoma too. So I don't usually take size that easily. And don't try to make a diagnosis outright either. So this is a pitfall that you shouldn't fall into. These are other samples. This was a case I saw recently of a sad case where the patient died. Yeah, EBV positive Hodgkin lymphoma in the setting of chronic EBV viremia. And the patient had recurrent palmoplantar warts. That clearly smells like something more than your average Hodgkin. And that's a T cell defect. And when you see these funny combinations, think of an inherited EBV susceptibility syndrome like X-Men or XLP. Yeah, I think that the patient that I had was possibly X-Men based on the constellation of things. But sadly, the patient did not give consent for genetic evaluation of siblings. So that came to a full stop with that. And so look beyond CHL. So it's not your job to just make a diagnosis and move on. That's a great reference for you if you want to ever read. Yeah. And for nodular LP, these are some samples that I use. This is a nodular LP with the typical pattern A. So I will mention the patterns when I see it. And this patient was clinically stage 1. They did not treat. They just waited and watched. And the second one I'll use is T/HRBCL with focal areas of nodular LP consistent with the THR-RBCL-like transformation in nodular LP. So make sure that you look for all components, low grade and high grade, when you look at biopsies, because low grade will persist after therapy. This is one where I say nodular LP typical pattern expressing aberrant CD15. And you have to explain why you still think it's nodular LP. It was negative for 30 and EBER. So you're not going to go and call it classical Hodgkin. Yeah. And this is one more sample where atypical lymphoid proliferation with a 4 and 8 double positive population, suspicious for nodular LP. So if you don't know, double positive populations have been described in the setting of nodular LP. Yeah. So Alia Rahimtullah described these populations. So remember, sometimes flow is useful even in the setting. Patient was asymptomatic, they did nothing clinically. This is one that you just saw, variant pattern, and the staging marrow showed transformation. Yeah, so sometimes you'll see this discordance all the time, and this patient was treated with CHOP-R. And those are your references right there for all of that. And with that said, this is one patient with pancytopenia. Anybody want to take a quick guess? This is an unusual lymphoma that occurs with only splenomegaly, no lymphadenopathy. That's a CD20 at the corner. This is a bone marrow biopsy. Anybody? Go for the chat. HCV. Yeah, HCV is a good thought. Hairy cell, but yeah, it's some nodular structures, right? That's not the pattern of hairy cell. And clonal TCR. Okay, hairy cell variant. Okay, good thought, but no. Marginal zone. Good thought, but no. Okay, one more. Okay, panelists. Anybody? Sashi, LPL, no. EBV associated, no. No EBV there. I'm already over time, guys. So let's get it. Hepatosplenic. Okay, that's not a bad thought, but no. Splenic module zone, no. That's CD20 in the end, I'll tell you that. Large granular lymphocyte. Yes, large granular lymphocyte can look very similarly with this very similar history. Yes, but I will tell you that these B cells on high power were large. Okay, that's your clue right there. No, it's not reactive, Imran. Okay, next. I will tell you that Jerome Burke and Ahmed Doan described this entity. Umadevi, good thought, but no. Hodgkin is a good thought, but it's CD20 strongly positive. Among all the entities I've taught today, what's the best fit with few scattered large 20s? Excellent. There you got it, Pradeep. T cell rich large B cell. Samriti is also right there. So this is a variant of T cell rich large B cell that involves spleen and marrow, called the micronodular variant of T cell rich large B cell lymphoma. So people frequently will do PCR on this. They'll find T cell clones and they'll want to call it T cell lymphoma. So be careful around this. You don't want to call this T cell lymphoma. So this is called PTSCL outside, treated with a couple of BCHP, and then the patient came. Okay, this patient was a 75-year-old male, and the final treatment was RCVP, 4 cycles. Yeah, because the heart was weak, they chose to get rid of the anthracycline. So CHL may show numerous tumor cells in strong 20. Be careful around primary infection. Variant patterns, we talked about that. PD1 and PDL1, we talked about the utility. The rosettes don't automatically make it nodular LP or Hodgkin's. So be careful around rosettes. EBER patterns we described and discussed. Look for B cell marker expression in relapse disease and to make a diagnosis of gray zone. And always do EBV and think of T cell lymphoma in a limited setting, and there's a limited utility of flow in some settings. Yeah, those are your take-home points right there. And that's all. I'll stop with that. We will stop all these unknowns for now, and I'll take any questions and we'll stop with that.
Yeah, thank you, Dr. Venkataraman. You've transformed this talk using your creative descriptions and soft clues. So I hope we have time for a few questions.
Yeah, I mean, I'm already over time, but if there are questions, we can, or maybe we can finish, Dr.
Yeah, maybe I'll ask 1 or 2 questions.
Sure.
Can RS cells have strong PAX5 positivity?
Yes, they can sometimes have strong PAX5, and titration of PAX5 is different in different labs, right? If I use a strong retrieval, my PAX5, even the weak ones will become strong. So never rely too much on the intensity business, and I have called Hodgkin's even with strong PAX.
Okay. Then another question is, what is your experience on gray zone lymphomas outside mediastinum?
Non-mediastinal gray zone. Yeah, you know what? I have seen more than a few gray zones outside. You know, in the early days, I used to call things gray zone even with few tumor cells. But in retrospect, I think I was not right in calling them gray zones in relapse disease. Usually, if 20, 30, and 15 are all present on the cells, then it becomes an easy call. But outside of that setting, gray zone is a tough diagnosis. I would strongly encourage that you get a second opinion every time you're trying to make a diagnosis of gray zone. Because half the time, it's found that most people are wrong when they make a diagnosis of gray zone lymphoma. A panel of experts looked at a bunch of gray zones across the country, and they found that more than half the times, people are wrong when they try to call it gray zone, and the expert panel looks. So I would strongly suggest have a colleague agree with you, have an expert agree with you before they go treat like gray zone. Yeah.
Okay. Now, having said that, what's the percentage of Hodgkin's lymphomas which show CD15 positivity?
For a good titrate at CD15, it's as high as 80%.
Okay.
But if your CD15 is not titrated really well, then you're getting to like 50, 60%. And I have seen that frequently and with CD15, because people should not use neutrophils as your internal controls, but your monocyte should be your internal controls. That should be positive in any biopsy.
Yeah.
Yeah.
Then, another question is, can CD79A be useful in CD20 positive CHL? Maybe two.
Yeah. I mean, 79A is useful. It's yet another B cell marker. It depends on what your question really is, right? Are you looking to prove that it's CHL, or are you looking to prove that it's a gray zone? If you're trying to prove it's a gray zone, then if 20 is positive and 79 is also positive, then it's very unlikely to be classical Hodgkin. It's probably something gray. So you'll probably end up doing OCT2 and BOB1 in cases like that.
Okay. I think the rest of the questions were answered during your talk.
Yeah.
So thank you.
Yeah, thanks so much. Yeah, it was a pleasure.
Thank you so much, sir, for the wonderful and interesting session. So we come to the last session of the day, for which I invite Dr. Shaini PM, Associate Professor, Government Medical College, Calicut, and also now Secretary to Calicut Path Alumni Association, to introduce our next moderator. Welcome, ma'am.
So good evening all. It's a great, am I audible?
Yes, ma'am. Yes, ma'am.
Good evening all. It's a great privilege and pleasure for me to introduce our own moderator for the next session, Dr. Neena Mampilly, Senior Consultant and Head of Department, Baby Memorial Hospital, Kozhikode. Madam has done her MPBS and MD Pathology from Government Medical College, Kozhikode. She is currently the President of Calicut Pathology Association, Path Alumni. Her fields of interest are hematopathology, flow cytometry, and breast pathology with 20 years of experience. She has almost 15 publications in various national and international journals and has presented so many papers in state and national CMEs. She is an enthusiastic, energetic, and passionate, and is inspiring for all the budding pathologists. Over to you, ma'am.
Thank you very much, Shaini, for that kind words. A warm good evening to all of you. So now we are coming to the last talk of the day, and it's a very exciting talk regarding molecular diagnosis of lymphomas. So most of us here are in fact morphologic pathologists. We report lymphomas based on our morphology using broad panels of immunohistochemistry. So, but our hands-on experience on molecular methods of diagnosis is rather limited because most of us lack in-house molecular laboratories. So we are a bit in the dark as far as the molecular methods of diagnosis of lymphoma is concerned. So we've seen from the previous talks that it's all coming to molecular testing that is giving away the final diagnosis in most of the cases that we've seen in the previous talks. So to enlighten us on this, on these various aspects of the molecular methods of diagnosis and much more on that, we have a very eminent molecular pathologist here today with us, Dr. Raju Pillai. It's indeed my great privilege and pleasure to introduce Dr. Raju, who also happens to be my undergraduate classmate. Well, Dr. Raju is currently Director, Pathology Bioinformatics, Director, Pathology Research Core Laboratory, and staff pathologist at City of Hope National Medical Center, California. He did his medical school from Government Medical College, Calicut, India, and his residency from the University of Southern California. He's got, he did his fellowship in molecular pathology from the University of Pittsburgh Medical Center, and also he did his fellowship in hematopathology. His certifications include diplomate in American Board of Pathology in anatomic and clinical pathology, molecular genetic pathology, and hematopathology. And he has got 42 peer-reviewed publications to his credit. and 13 published abstracts. He's written 3 chapters in books relating to diagnostic molecular pathology in practice, case studies in hematology and coagulation, and pathogenesis of lymphomas. He's an invited faculty for international seminars and lectures, and he's got a patent application for which is pending for HOP ESEQ next generation sequencing analysis platform. So going through his publications, Dr. Raju has made major contributions in double-hit lymphomas, in the molecular analysis of double-hit lymphomas, follicular lymphomas in situ, and colorectal cancer, in addition to molecular studies in lung cancer and breast cancer. So welcome, and Raju, and over to you.
Good evening, everybody. Dr. Neena, it is my great pleasure to have you introduce me to this audience. It's been quite a few years since we were undergraduate students in Calicut. So let me first share my screen, and please let me know if audio and video are okay. Can you let me know if the audio and video are okay?
Yes, see, audio is okay.
The slides?
Yeah, slides not yet come. Yes, it's seen.
Okay, thank you. So first of all, I'd like to thank Dr. Rajan and the organizers for inviting me to give this talk. So in addition to my clinical work, I also have been involved in developing molecular assays. And so I'll share some of my perspectives about what is most important, what is useful, and what is not.
Screen
The screen is not correct?
It's okay. It's voice is slightly less.
How about now? I mean, can someone else tell me if the screen is okay?
Yes, it's okay now. It's okay now.
Okay,
That's good.
So these are the areas that I'd like to cover today. As Dr. Neena said, molecular testing is not very widespread, even in resource-rich countries in the West. So I would, and it would be difficult in an hour to go through all the technologies that are available and do justice to it. So I'm going to pick and choose certain techniques that we use more commonly in our practice, and then go into details on that, and hopefully you'd get a flavor of what is currently being used in our practice. So I'll be going over the role of molecular testing, an overview of the molecular techniques. I don't plan to go into the details of individual techniques, but more like what assays, how do they work, and how do we interpret the data. And then 3 specific topics would be antigen receptor gene rearrangement, cytogenetics, and next generation sequencing based methods. So first of all, how do we use molecular techniques? So I would classify them into 3 or 4 major categories. One is diagnostic use. So sometimes you are dealing with the proliferation. Dr. Venkataraman showed you some really nice cases, immunoblast with CD30 positivity. where you are trying to distinguish whether this is reactive proliferation or not. Sometimes it is useful for disease classification. So for example, you are trying to decide if this is hairy cell or variant hairy cell or some other splenic low-grade lymphoma. A molecular test could be very helpful. It is used for prognostication. IGHV mutation status in CLL correlates with outcome. It's also used for therapeutic reasons, which is mostly rare, but there are some clinical trials where the patient needs to have a certain mutation to be enrolled in a trial. For example, ECH2 inhibitors in follicular lymphoma. BTK mutations in the age of BTK inhibitors, ibrutinib and others. If there is recurrence of disease or the disease is relapsing, one thing to look for is, are there mutations in BTK that are causing resistance? Minimal residual disease will become more important in the future. At the moment for lymphomas, it is not used as much as leukemias, except in the setting of clinical trials. So what are the assays that we use? Now, this is not a comprehensive list. This is just a list of techniques that I find most useful. So you have the cytogenetic classical assays, G-banding, FISH, and microarrays, out of which FISH is the most consistently used. Then you have antigen receptor, B-cell receptor and T-cell receptor based rearrangements, which would be IgH or IgK gene rearrangements, T-cell receptor beta and gamma rearrangements, and then also IgHV mutation analysis. And again, IgHV mutation is used for minimal residual disease detection as well. So this is much more commonly used, so I'd be spending more time on that part. Next generation sequencing in lymphoma is becoming more useful, and as sequencing costs decrease, the expectation is that it would be more widely available, at least in reference labs. So we have single gene assays, targeted gene panels, exome sequencing, RNA sequencing. These are all available clinically now, at least in the larger centers. And I'll explain how we use it and what are the potential benefits of this. So one of the major drivers of adoption of next generation sequencing is that the cost of sequencing is going down every 2 or 3 years. So what used to, a single genome that used to cost $100 million now is $1,000, and the expectation is it will go down even more. So I'd like to start with the case. So this is a 60-year-old male with left inguinal lymphadenopathy. And here is the histology. Because you had such wonderful presentations before, the histology pictures that I'm going to show you will be very brief. So this was, the biopsy was very small, which is always a challenge for lymphoma. There were some vaguely nodular areas, and in high power, you can see there is slight atypia in some cells that look more like centrocytes. So here is the CD3 and the CD20. So you can see in the CD20, there are clusters of cells that look like follicles, but on the H&E, you can see there is no well-defined mantle zones. It doesn't look polarized. And CD3 is rich in the extrafollicular space. So here is the CD10 and BCL6, confirming that they are indeed follicular structures. And from the H&E, if you remember, they don't look like typical follicles. The BCL2 on the lower left was negative in the follicular cells. Interestingly, the Ki67 in the follicular areas also was low, which is sometimes helpful to think about whether this is reactive or follicular lymphoma. So for the first poll, which of the following is the best next step? Can we have the poll, please? Okay. Let's stop the poll. So the majority of respondents wanted to do FISH, and about a quarter wanted to do molecular studies, and a smaller percentage wanted to do the other steps. So again, the option C, the 100/D5 clone, is the the original BCL2 antibody, and the SP66 and the E17 clones are much better for some cases that are FISH positive but IHC negative. The SP66 and E17 clones sometimes will pick up BCL2 positivity, but the 100D5 clone is the original. That may not be useful. So the other two are both useful. And sometimes if BCL2 is negative, the FISH tends to be negative, but we did both. The M7 FLIPP genes is more of a clinical trial at this point. So this is a set of 7 genes, epigenetic genes mostly, that are used for predicting the prognosis of follicular lymphoma. That is only done in the setting of a clinical trial. Okay, so moving on. So this would be a good time to segue into IGH gene rearrangements. So what is, how do we do IGH gene rearrangement? So it is really a marvel of biology that with a few genes, a human body is able to create antibodies that can technically be specific for over 1 billion antigens. You know, so we get tremendous diversity, but then if you look at the actual DNA, there is only about 40 VH genes, about 25 DH genes, and 6 J region genes, and then there are 5, 6, no more than that, maybe 7 or 8 heavy chain genes. So with these few genes, the human body is able to create antibodies that can potentially recognize close to 10 billion different antigens. So how is it done? So you take a VH region, combine it with the DH and JH. This is all done in DNA, and this is done way before lymphoma develops. This happens in the bone marrow at the time a hematogone becomes a B cell, and it is fixed at that time. And then in the RNA level, the VD and H, VDJ is already combined in DNA, and then this is spliced out to create an antibody. Now, this gives us a unique opportunity to identify malignancies from benign proliferations, because since the hypothesis is malignancies arise from a single cell, the VDJ rearrangement is preserved throughout the development of lymphoma, and we can detect it. So how do we do it? So the VDJ this is the VDJ part. And if you look at VDJ, there are some regions within the VDJ, which is highlighted in purple, which are relatively constant. And the other parts in blue, FR1, FR2, FR3, those are the framework regions that are relatively constant, not changing. And the areas in between, the purple regions are the ones that change. This is all within the VH region. Now, the reason why this keeps mutating is that's how antibodies become more highly, the affinity goes higher because of changes in these purple regions. So when we design assays, we tend to use primers. These arrows are showing you what primers are used. So if you put a primer on the framework regions and a primer on the opposite end, you will get a PCR product that will have a specific length based on which V and which D and which J was selected. And you can see that both FR1, FR2, and FR3, they're all picking up from the same VDJ, but because the length is different, you would get different size products. So the 2A in FR1 is 310 to 360 base pairs. You'll see why this is important. Now, every B cell is slightly different. So you would get a range of sizes with the peak in the middle, like this. So this is an assay from a negative sample that was run in our lab. So this is FR1, it's between 310 and 60, and you see this pseudo-Gaussian distribution. If you look at FR2 and FR3, they also look like this when it is negative with multiple peaks. And again, the peak intensities are also kind of low. It's usually in the 2000 to 4000 range. Now, how about kappa? Kappa is the same principle with the twist. So again, there is V and J, but there is no D region in kappa. So it is a V to K, a V to J rearrangement, which is shown by this part, the blue and the green. And then there is the constant, and the twist is there is an element called a DNA sequence called kappa deleting element. So what that does is, okay, so before we get to that, so again, the rearrangement happens in DNA in the immature bone marrow cell. So VK and JK will join together, and then it will join with CK at the RNA level, and then that's how you get your light chain. So again, if you when we keep primers in different regions of the VK, and then put a reverse primer on the JK, and that's how we get our PCR product. Now, what is important in kappa is that there is this KDE element, kappa deleting element, which can recombine to the middle of the V kappa region. So what that will do is it will knock everything in between out, which means there is no constant region, there is no J region, which means there is no kappa. And that is how majority of our B cells switch to lambda. It can also combine in the middle of the intronic sequence. That also will knock out kappa. So about 90% of human B cells, the Ig lambda B cells, switch kappa through this. And it's also present in 10% of Ig kappa B cells, because you have two kappa loci. Even if one does this, the other kappa can still make it a kappa light chain. So the design of the kappa PCR also, in addition to the V, it also includes the KDE and this intronic region to pick up the rearrangements where the J is missing. So this is what the kappa looks like. Again, this is a negative sample, but because the kappa repertoire is limited, you have certain non-specific peaks at 148 and 197. And this is consistent. If you take most normal people will have this 148 and 197. So it's something that we got used to. And now there is a possibility that an actual lymphoma peak could come under 148 rarely, but then it will become very difficult to diagnose that. And then you rely on the heavy chain tubes to diagnose that. And this is what the kappa B with the kappa deleting element, etc., looks like. One caveat to interpreting the IgH and Ig kappa is that sometimes the peaks go outside the range that is calculated, and which is okay. You know, biomed range only includes 5 to 95%. So when we say FR1 is 310 to 360, that only captures about 5 to 95%. So slightly outside is okay. And the reason for that is when D and J join, the body has a mechanism to increase diversity by adding and deleting nucleotides while the DJ junction is made. So this is not a well-defined perfect junction. Every B cell adds to few nucleotides here and there. So sometimes the sizes can go beyond. Some pitfalls and lessons learned. Clonality on a molecular test, let's say you send it out and comes back, this is positive for B cell IgH gene rearrangement. That does not equate to malignancy. There are also some instances where a light chain restricted B cells, when we did the molecular, it turned out to be negative. So even light chain restriction does not make it clonal. Viral infections are notorious to produce positive results in IgH and IgK. Autoimmune disease is another one. And then there are aging-related T-cell gene rearrangements that can also be, look apparently positive. So it would be prudent to keep a skeptical mind and make sure that your histology and IHC and the clinical history all fits with the molecular result. I mean, coming from a molecular guy who spent a lot of time on this, I think I still try to keep the molecular and the histology and the immunohistochemistry, they have to make sense with each other. Clonality by PCR has a sensitivity of about 5%, and there is this phenomenon of pseudoclonality, where if the number of B cells are really low, you might get a peak because there are so few B cells, they tend to preferentially amplify. And that has been sometimes mistaken. And there are two ways to avoid it. One is to make sure there is, before you order IgH, IgK, there should be enough B cells, and you're considering, you're willing to call it a B cell lymphoma if the results come back positive. It should not be, okay, let's do T cell, B cell, everything molecular for this case. Use all primer sets, not just the heavy chain, use kappa as well. Sometimes it's very useful. False negative results can occur because the primers don't bind, because the IgH gets mutated in the germinal center. This typically happens in follicular and the LBCL. The other rare causes, IgH deletions and rearrangements, can also give you false negative results. So take it with the skeptical mind. And so coming back to our case, so we had this patient, we did IgH and IgK. So again, here, let me walk you through. This is the FR1 or the IgH-A tube, which is clearly positive. Again, the intensities are way above what you see in reactive. It's like 35,000 intensity. It's a single strong peak. There's not much of a polyclonal background. This is FR2. Again, now you can see a separate peak outside. The significance is uncertain because it is quite outside the range. And for FR3, now you see a double peak. Both are within range. So Ig kappa, this is what I was telling you before. Normally, the 148 is the strong peak, and here it is 197, that is a strong peak. So this is considered abnormal. And for kappa B, this is the KDE tube, and that is also positive. So this is how you would go about interpreting B cell receptor gene rearrangement. So in this case, because the morphology and IHC were very suspicious and it was confirmed by molecular studies, even though it was a tiny biopsy, we called it follicular lymphoma grade 1 of 3. Now, so what we talked about was, okay, how do we use B cell receptor gene rearrangements for diagnosis? But we are now learning a lot more about the molecular alterations. So primarily, we would look at it as, what are the large chromosomal level alterations? What are the gene level alterations? What are the gene expression profiling? Now, this is becoming more and more well established, and slowly trickling into clinical practice. So in terms of cytogenetics, yes, there is the 14-18 translocation, 80% of adults, absent in pediatric type FL, BCL6 translocations in 50%, trisomy 18 and 7 common. But what is very interesting is when you start sequencing these cases, there are a bunch of epigenetic genes that are very common in FL. FL is as much a genetic disease as an epigenetic disease. And epigenetics is basically regulation of gene expression by changes in DNA. So it involves changes in histones, it involves changes in methylation of the DNA, especially in the promoter regions. So histone methyl transferases, KMT2D, and this is also known as MLL2, and ECH2. These are very, very frequently mutated in follicular lymphoma. And there are now drugs that can target ECH2 mutated follicular lymphoma. So when we think about the role of ECH2, do you need it for diagnostic purposes? Probably not. But will you need it to treat people with targeted therapies? And targeted small molecule inhibitors, unlike the monoclonal antibodies and the cellular therapies, are much, much cheaper. So ECH2 mutations, what they do is they increase the trimethylation on the histone H3. There are targeted therapies. The other very commonly mutated genes in follicular lymphoma, the CREBBP, EP300, MEF2B, they're all, again, histone acetylation genes, and decreased acetylation of BCL6 causes. BCL6 is a transcription factor that activates so many genes, and if there is altered expression, that affects how BCL6 works. And then at some point in follicular lymphoma, there is transformation, and there is many other genes that get mutated: TP53, MYC, MYD88, the NF-kappa B pathway. So what is the role of molecular studies? It might be useful in future to understand transformation or early transformation if these genes can be analyzed. Okay, so we're done with antigen receptor gene rearrangements. Now we'll move on to fluorescence in situ hybridization. This is also very commonly used. So out of the cytogenetic techniques, you have classical cytogenetics, the karyotyping, FISH, and then microarrays. We don't use microarrays as much for lymphoma, even though technology is available. And there are two types. One is a SNP array, which is used in fresh tissue, typically for CLL, myeloma, and leukemias. And then there is an FFPE-based assay called a molecular inversion probe. It's called OncoScan. That works from paraffin tissue, and that is the one that is more commonly used in lymphomas. I don't find it super useful. So FISH has much higher resolution than G banding. It's got a 50 kilobase resolution, and you can detect balanced translocations. You can detect unbalanced. You can detect intrachromosomal rearrangements, copy number changes, amplification, allelic loss, and deletions. And since most of you would be familiar with FISH, I'd briefly make some remarks for the trainees. So there are two types of FISH probes that are used for lymphoma. One is the break apart probe. In a break apart probe, there are two probes that are targeted at the same gene, let's say MYC. So if you have both orange and green together, then that's considered normal. So red-green fusion is normal. If there is a break in the gene, the two signals will separate, and then you get a separate red and green signal, which is what is shown in the top picture. The problem with break apart probes is you will know that the gene has a rearrangement, but you will not know what is the fusion partner. But that's also an advantage because you don't need to know the fusion partner. You just will be able to find out if MYC or KMT2A or IGH has a rearrangement, as opposed to the double color double fusion probes where the two reds and the two greens are normal. And then if there is a translocation, the red and green come together. So the red-green fusion signal, sometimes you will get two signals because the translocation will have derivative two derivative chromosomes, and both of them will create fusion signals. So this is the typical signal patterns that is used for diagnosing fish abnormalities. So now we'll go to the second case. I think we are still okay with time. So it's a 75-year-old male with cervical lymphadenopathy. So here is the histology. So, on the top left, you can see a low power view. So it's a relatively small lymph node. The capsule is kind of thick. There is some infiltration of the capsule. There are some small follicles, but otherwise the architecture seems effaced. And then there are these pink epithelioid histiocyte clusters. On a closer power, higher power, so there are some lymphoid follicles that seem to be somewhat regressed. There's a mantle zone around it, and then there are these clear cells that are surrounding these follicles. This is another shot of that, and here is the higher power picture of those clear cells. Vesicular chromatin, clear cytoplasm. So we did a panel of stains. That pattern that I showed you is very suspicious of an entity. So here is a CD20 highlighting the B cell rich areas, and then the mirror image is the CD3. And the CD3 happens to be mostly CD4 positive cells and much less CD8 positive cells, although there is a good mixture. And in the CD4, you can also see the weak stain, that's the epithelioid histiocytes. Here are the, well, I gave it away now. Okay, so here is the PD1 stain. Again, this is the follicle with the T follicular cells staining strongly with PD1. And some of these clear cells seem to have PD1 staining, also CXCL13 stain. The Ki67 is slightly higher. I mean, there are some germinal centers positive, and also the T cell areas seem to be positive. And then Eber stain, which Dr. Venkataraman described so well in the last talk. We saw, you have to be careful about interpreting Eber, but there were a few scattered positive cells. So we did a molecular study, but it was negative for T cell receptor gene rearrangement. So this is going to be our segue into next gen sequencing. What is it? How is it done? How do you interpret the data? So for the next question, which of the following is the raw sequence data that is produced by a DNA sequencer? Can we have a poll, please? We'll give it another 10 seconds. Okay, let's close the poll. So I think a good number got the answer correct. That is FASTQ, 31%. And so, a few years, maybe 10, 15 years ago, I had no idea about all these as well. But then it is becoming much more and more common. And I think it behooves well for us to just be familiar with some basics. So I will not go into the gory details of how NGS is done, etc. But from more of a perspective of informed user, a pathologist needs to be aware of and be able to talk the language of the lab. So NGS is a relatively simple concept. So so there are basically 5 steps. You isolate DNA from paraffin or fresh tissue, wherever, and then you fragment DNA. It can be fragmented by an ultrasonicator, which used to be more common, but now it's done using enzymes. So you basically break it up into smaller, manageable fragments. And then that's the whole genome. So we don't want to sequence the whole genome because that's too expensive. So we want to target certain regions. It could be 50 genes, it could be 100 genes, 200 genes, whatever number is in your panel. So we use probes. That is shown by this little green, sorry, something happened. Okay, so that is shown by these little green probes, which are basically capture probes. So based on what genes you want to capture, you will design those probes and then pull down the regions that you want. Once you get those regions, you add little adapters to both ends, and these adapters enable it to bind to the flow cell. Flow cell is basically a glass slide with little holes in it. And these adapters will enable it to bind to the flow cell, and the flow cell now reads off the sequence. So this is essentially what next-gen sequencing is about. So if you look at the steps, you have DNA, you fragment it, you make a library prep, which is basically fragmenting it and then adding some adapters to it. And then you enrich the targets, and then you sequence, and you get what is called a FASTQ file. Now, what is a FASTQ? So the output of NGS is FASTQ files, and a FASTQ file is basically a text file with a lot of lines, hundreds of thousands, sometimes millions of lines. And what do these lines show? It shows, okay, flow cell cluster, which is the area of the slide that it came from, the sequencing flow cell slide, and then it also has a sequence. It tells you the exact letters, the nucleotides. And it also has a quality data below that. And here it is shown as a graph. Sometimes it's shown as a number. And the number basically says how good your sequence is. If the score is 20, that means you have a 1 in 100 chance that it is wrong. If the score of 30 is 99.9% accuracy. So anything above 30 is considered very good sequence. What do you do with that data? So at the end of sequencing, you get a big file, a FASTQ file. And then you take that file, run it in a software, and that software takes each of those millions of FASTQ reads and finds out which part of the DNA it aligns to the most. It won't align perfectly because there might be mutations, but most of it will align. Out of 100, maybe 95, 96 will align. So then you get what is called a alignment plot, which is also in the bioinformatics language, it is called a SAM file or a BAM file. So when you visualize it, it looks like this. So each blue one is a read going in the forward direction, which means P to Q, and each red one is a read going in the reverse direction because we sequenced both strands. And then what is the final output? So that particular alignment is used to compare with the reference and say, okay, what is different? So you can find there are differences in single nucleotide variants, there are insertions and deletions, sometimes the copy number is high. So what are some examples? Single nucleotide variants. So there could be silent variants, which means a letter changed, but the amino acid didn't change. Missense mutations, which means a letter changed, but the amino acid now changed. So this is an example of the V617F mutation that we see, JAK2 mutation in ET and myelofibrosis. There is nonsense mutations where a letter change led to the protein being truncated and stopped. That's what happens a lot in cystic fibrosis. Then there can be indel mutations, which means more than 2 or 3 base pairs were deleted, which happens in EGFR and lung cancer. And then there are copy number variations of TP53, important in CLL, duplication important of MYC duplication in neuroblastoma. Sometimes you see BCL2 and BCL6 copy number changes in follicular and diffuse large B-cell lymphoma. Once that is all done, you get a list of variants, and that is called a variant call format or a VCF file. Essentially, it says in chromosome number 1 at this position, the reference was an A and now it is a T. So that's all what a VCF file is. And if you visualize it, you can line it up against the reference sequence and say, okay, oh, this is supposed to be a G, and the software is highlighting that it is changed to a T. So it is just calling the G to T as JAK2 V617F. This is what an indel looks like. It was supposed to be a C and a G, and suddenly a bunch of nucleotides have been inserted in between. So this is the whole workflow. So this is the wet lab part. This is the bioinformatics part. So you go from DNA to a FASTQ file, and in the bioinformatics part, you align it, call the variants, and then decide what does this variant mean, and then interpret the significance, and then create a report. You must all have started seeing these reports that are coming in to say, okay, we found this mutation. So we are supposed to use human genome organization nomenclature, and that nomenclature is relatively simple. So you have genomic DNA. So let's say there are 3 exons in this gene, for example, BCL2, there are 3 exons. What is shown in yellow is the areas of the gene that are not made into protein. Only the light green and the dark green are actually made into protein. So when we describe the mutation, we always start with the areas that are converted to protein, and that starts with the first codon, which is ATG, which codes for methionine. So the ATG is the first protein coding nucleotides in this gene. So we start that and call it, the A is the C.1, T is C.2, and go on. So then if you count like that, you can say, okay, from the beginning, where is the mutation? So one example would be C.123, A has been changed to G, or C.123, A is missing, deletion A, and there are a lot more details at this website. So this is how mutations are described. And when you get this report saying this is C123, this is basically what it means. Let's go back to our case. The patient with the lymphadenopathy. This is what the molecular studies came back as. So let's go through it slowly. So DNMT3A is also a gene related to epigenetics, methylation. So C.2173 basically means from the start of the protein coding region, the 2173 nucleotide plus 2 means it is outside the coding region. That's why it's called a plus 2. Otherwise, we would have just said 2175. But because this is not protein coding, we call it plus 2. So it's moving into the intron. T has been changed to G. Now, what is the significance? Well, the first 1 or 2 nucleotides can affect splicing and actually can lead to loss of protein. So this is considered important. Well, if it were plus 5 or plus 10, then probably it will not be considered significant because only the first 1 or 2 will affect splicing. And that was present in 24.3% of the total sequences that were read. But you have to remember that in most cancers, mutation affects only 1 copy of the gene. So that means when you say 24%, that's 48% of cells are malignant, and that's why only 1 of their copies is. So usually you have to double. The other mutation was in a gene called RHO-A, which is involved in T cell migration. There was a mutation in TET2, 2 mutations in TET2 actually. So and the second mutation is basically a change of, this is a missense. So glycine changed to valine. This one is interesting in TET2. Between 27 and 28, 2 bases were inserted. And because 2 bases were inserted, it threw the whole protein coding sequence out of frame. And then the protein ended shortly after, about 20 bases after it. So there was a mutation that destroyed TET2 function. There was another one which actually said T to G at 5081, and what it led to is L1694, and this asterisk means a stop. So the protein basically, the mutation created a stop codon, and it stopped making the protein. So typically these 2 are probably in both copies. Usually it doesn't occur in the same copy. So it basically knocked out both of the TET2 genes. So this is how you would read that molecular report. So molecular alterations in AITL, as we discussed before, now we have to look at cytogenetics, molecular, and gene expression, the three different aspects of molecular. So cytogenetics, trisomy 3, trisomy 5, and addition of X are most frequent. AITL is an unusual disease in that there is a lot of unrelated clones. If you were able to look at them individually, the tumor cells individually, that is very unusual in lymphomas. Usually it is the same clone that's expanding, but AITL, you get a lot of unrelated clones. And 10 to 25% of cases even are molecular negative or even cytogenetically negative. Now, this is thought to be a lymphoma in evolution. It's slowly becoming a lymphoma. So it's not become a single dominant clone yet. And these are the alterations that are most common in AITL: TET2, DNMT3A, IDH2, and ROA. And except IDH2, all the other mutations were present in the sample. So we called it angioimmunoblastic T-cell lymphoma. And we explained all these mutations, and the morphology and the phenotype was very supportive as well. The last part we'll talk about, this is not yet in common use, gene expression profiling. So essentially the process, the technology is very similar. Instead of starting with DNA, now you're starting with RNA. You convert that into DNA, so complementary DNA. Then it's the same process as before. You cut into pieces, add adapters, put them on a sequencer. What happens to the data? Again, it is aligned. You create a BAM file just like before, and then you quantitate for each gene and for each exon, how many copies of RNA was there. That is the raw data in RNA-seq. Now, what do you do with it? Once you get the read counts, you can look at differential gene expression. You can look at, are there combinations of genes that are enriched, which is the gene set enrichment analysis. You can look at gene fusions, some of them, not all of them. You can even use the RNA-seq data to see if there are variant calls. Now, what are some applications? So the Lymph2CX, or the diffuse large B-cell lymphoma cell of origin prognostication, was originally developed as an RNA-seq assay of about, I think, 20-something genes, but then has been largely replaced by an immunohistochemistry, which more or less matches the results of RNA-seq. But there is a lot of interest in using this gene expression data for determining prognosis, determining therapy, etc., but still early days. So we come back to what are the techniques that are used currently. So FISH and gene receptor, antigen receptor rearrangement are definitely the most diagnostically useful. Next generation sequencing is useful in selected cases. Exome sequencing and RNA sequencing is now available in big centers, and there are some early efforts to also do additional omics type of assays. One is to look at epigenetics, especially in lymphomas like follicular. Mirnome is basically microRNA sequencing. It is very similar process, but microRNAs are really small, 20 base pair, small RNA molecules that their role is they bind to our classical messenger RNA and stop the function of messenger RNA. Interesting thing is one microRNA can stop the function of several genes. So microRNAs are important in the cell biology of lymphomas. It is very early days for that. Epigenetics is important in several hematologic malignancies. Definitely in AML, the HDAC inhibitors, which are clinically used, depends on modifying the epigenetics. And then there are combinations of HDAC inhibitors with or methylation drugs with BCL2 inhibitors that are highly effective in AML. So epigenetics will become a more important component. Spatial transcriptomics is the new kid on the block. Essentially, it is RNA sequencing, but it is done on an FFP slide, and the pathologist will get to pick and choose which areas to sequence rather than grinding up the whole tissue and doing RNA-seq. So you can say, okay, I want to look at this area that is rich in lymphoma, and you can even pick out individual cells too if you want. And then you can say, okay, what about the microenvironment? What is the gene expression in that? Now, these are very early days. I just mentioned it because this technology is now available, and it's good to be aware of that, but it's so far from being used in diagnostic pathology. So except the big academic centers, even in the West, many of these assays are not available in most hospitals. So how do you think about incorporating these in your practice? So one approach, I mean, there is no easy solution, but one approach is to think about it as a multi-layered testing policy for the hospital and say, these are our basic tools that we need, morphology, immunochemistry, basically. And then the other assays with high clinical impact, for example, FISH or gene rearrangement assays, even if it's not available within the hospital, if there is a reference lab, use of reference labs will reduce the physical infrastructure cost, because a lot of these are volume dependent. If you do not have volume, it is not easy to run it economically, especially sequencing. You need a large number of samples to make it cost effective, to use big sequencers. So reference labs could be one way to reduce the cost and increase availability. And then it's always good to, before any testing is done, to see, okay, what if there is a positive result? What if there is a negative result? Well, if you're going to give R-CHOP either way, then probably you don't need to distinguish between two entities that are closely related. Or if there is other reasons that that option is not available for treatment, then so that has to be always kept in mind as to what is the goal of testing. So the last 3 or 4 minutes, I'll give you some interesting history about City of Hope. So it started over 110 years ago as a TB sanatorium, and this is one of the first pictures of 2 little canvas sheds that was put up to get the TB patients out of Los Angeles into, where at that time air and sun were the only treatment available in 1910. So this was to get them out of the city. They created this institution, and this is 10 years later. Now there is some buildings, and people are getting their sun and air outside, and there is a doctor visiting them. In the 40s, once TB got under control, the major focus shifted to cancer. One of our previous chairs was Henry Rappaport, who created the first classification of lymphomas. The room he used and the slides he used and all those are still in the department. It was interesting to me. In 1976, the first bone marrow transplant was done for AML. So it was an early pioneer for bone marrow transplants. Some of these things that are not very well known. The first human insulin was created in City of Hope, and that patent provided a lot of revenue for research for a long time. The other major invention was the humanization of mouse antibodies. So before that, there were, it's okay, you can develop antibodies in mouse, but people develop resistance to those antibodies very quickly. And it's one of the labs in City of Hope developed a technology to humanize it, just taking the antigen receptor binding regions and putting a human backbone on it. And that patent has been the basis for creating Rituxan, Herceptin, many of the antibodies that are used today. 2011, the 10,000 bone marrows were completed. So in our practice, there is a lot of bone marrow biopsies that we review for transplantation. This is what it looks, City of Hope looks like now from that little shed years ago. I thank you for your attention, and we have about 10 minutes for questions.
Thank you very much, Raju, for that wonderful lecture. In fact, that was really a very crisp and very simplified way of understanding next generation sequencing for all of us. Now we have a few questions. Do you do clonality by NGS? And what percentage of clonal cases do we miss if we do only RT-PCR?
That's a very good question. So we have implemented NGS. The reason why we don't use it routinely is the turnaround time. NGS takes, because you have to go through all the process sequencing, data analysis, etc. It takes sometimes 5 to 7 days to get a result, whereas PCR, you can typically get it in 2 days. So, I tend to use PCR more. The other thing to consider is with PCR, you are interrogating multiple regions of the immunoglobulin gene. So you have the 3 heavy chain, the 2 kappa chain, and there is even some lambda PCRs. So unless you do all these regions with NGS, the sensitivity may be lower. But if you did all of them, if you did IGH and IGK, what is reported is the sensitivity is either equivalent or more. So the original studies of PCR from, it was done as an European consortium. The Biomed2 was a group of pathologists from different countries in Europe who got together and analyzed the same samples using the same method. In their study, many of the non-germinal center derived lymphomas, the sensitivity is pretty close to 100%. And the mutated ones like FL, DLBCL may be lower, but if you include IGH and IGK, you'll pick up most of them. So you don't lose a lot of sensitivity by doing PCR. It is faster turnaround, but NGS, even though I don't have personal experience, is reported to be equally good.
Thank you, Raju. I don't think there are any more questions. Just compliments for you from everyone.
I'm glad it was useful.
Thank you very much.
So, Dr. Rajan, so I'm going to log out, I guess.
So wonderful talk, very clear, lucid. Hello, Raju?
Yes, I'm still here. Yeah, I'm still here.
Yeah.
So I'll wait a couple minutes if if there is more questions.
Yeah, Raju, I have a question for you.
Yes, Girish.
Yeah, like, do you use a single NGS panel for all lymphoma and leukemia, or do you have separate panels for both NGS? Because we use it in lymphoma less frequently.
It's a very good question. So most of our panels we developed in-house because early on when we were getting into AML, NGS, there was nothing available commercially. Now there is a lot of good options. So we developed the myeloid panel, and then all the lymphoma docs wanted their own genes because they were doing clinical trials, or they wanted prognostic genes, they wanted MID88, etc. So if you were to consider a full lymphoma panel, that would get in excess of 100 genes. But if you only want the most clinically actionable ones, then you can combine it with the myeloid panel. So our current strategy is to combine the most useful lymphoma genes with the myeloid genes. We are at around 135 genes. Avoids running 2 panels and all the complications associated with it. It's much easier to run a single panel for both. But if your clinicians want more and more genes at some point, if it's still 100, 200 genes, you still can manage with the single panel.
Okay.
Yes, Raju, there is another question. When to go for T-cell clonality study in lymphoma? Is it all T-cell NHLs?
No, so we tend to use it selectively. If your histology and immunohistochemistry are clear-cut, in many cases, we will not do a T-cell gene rearrangement. But if even if you have some slightest doubt that this could be, so for example, angioimmunoblastic lymphoma, there are some cases that may not be a clonal proliferation. So those cases, if you want to be sure, those are the cases we will send for molecular. The second scenario is recurrences. So patient had treatment, chemo, maybe a transplant, and after that comes back with a lymphadenopathy. And in those cases, if it is suspicious, it is good to compare with the original clone. Skin lymphomas tend to get more T-cell gene rearrangements because sometimes it's hard to, with a small skin biopsy, to make sure whether it is a reactive or something like a cutaneous T-cell lymphoma. There are quite a few caveats. I find it challenging to interpret skin NGS. Drugs can cause clones. Reactive things can cause clones. There are few cells to begin with. They're not ideal scenarios, but if a dermatopathologist needs that additional evidence, it is worthwhile doing it. But with a good dose of skepticism to use that data. It could be a clone, but that clone could be a drug-related clone. It could be a reactive clone. It could be an infectious clone. It could be a lot of things creating clones.
There's another question. How to differentiate oligoclones in T-cell lymphomas from true monoclonality?
Oh, that's another difficult problem. So, so there are two things here. One is, what is the proportion of the area under the curve for the clones? So if you have a very strong peak, that is classically, in many molecular pathology labs, we used to use 3:1 ratio, which means if your highest peak was more than 3 times the intensity of the second peak, that was considered. But I don't use that routinely because there are several issues with it. One, your second peak could actually be part of the tumor itself. You can have multiple clones coming from the same T cell. The T cell receptor may be rearranged in one allele, and then if it's not productive, it will rearrange the other one. So you could get 2 clones, and then both clones might be part of the lymphoma itself. And then the second consideration is pseudoclonality. Are we dealing with? So we always talk to the hematopathologist or to see, what is his impression? Are there, is he considering a T cell lymphoma? Is there a lot of T cells there, or are we dealing with, very few T cells? Pseudoclones can look oligoclonal because there will be like 2 or 3 peaks, and that's just because there are very few T cells in this original specimen. The third thing is, you try to correlate with between the different, so you have 5 different PCRs. There is the beta, gamma A and gamma B, and then beta A, B, C. So you try to look at all of them together and see if the patterns match. You also look at whether the polyclonal background is strong, or, usually in lymphomas, the polyclonal background gets suppressed because most of the T cell products are coming from the lymphoma. So that is challenging, and we have a molecular pathology group that meets every day, basically. Those are primarily for interpretation of NGS, and I would strongly advise any of the institutions who are trying to establish these new technologies to have a regular meeting between the pathologists involved in the sign-out. It has helped us tremendously, so we have 4 pathologists and 2 or 3 PhDs. We meet basically every day to go through NGS and discuss. It's very useful to get different perspectives. And if there are challenging T cell cases, that also is presented at the meeting. So whoever is signing out will present the case, and it's up for discussion, and usually we can resolve it, but it's a tough challenge.
I think we have one more question here. Developing in-house assay or customizing your panel, can you guide on validation part in NGS?
Okay. So the first thing to, so since we have developed a few panels, I think I can talk a little bit about that. So first thing is, are there commercial panels available? If there are, like for example, for myeloid, there is an Illumina panel, there is an iron tolerant panel. There are panels available. If you go with any of them, the cost versus running and developing your own panel is not significantly different, but you get a ton of help from the company, as well as there are a lot of publications using that particular panel. So that's one thing to keep in mind. Developing your own panel, once you have done a couple, it is easier. But the first 1 or 2, at least in our case, was horrendous. You don't get the performance that you expect. Some regions are not covered well, so then you have to go back, change the design. Every time you change design, you have to buy more. So it is very expensive to do custom panels, and that's why many labs tend to avoid it. And it's not going to save you a lot of time. And the third thing is, it takes time to build up expertise at the technical level in the lab, as well as for the pathologists who are interpreting it. So if there is that level of resource available, at least I would say, if you have 2 or 3 people signing out molecular, and you have a lab that has a few technicians who are doing PCR, then it is definitely feasible to develop your own custom panels.
Okay, thank you. I think our time is more or less over. Rajan sir.
So today, the second day is, we are completing the second day. And thank you, all the faculty, Dr. Jayalakshmi, Dr. Girish Venkataraman, and Dr. Raju. Thank you very much. And you see that this topic is a tough topic, because many of us, we are actually not having a dedicated molecular lab. Since some attempts are coming up, and Calicut, we are establishing a multidisciplinary research unit. So we are doing PCR also. They are starting PCR, but no dedicated lab in Kerala, and people are sending materials to Mumbai or some other labs. So I need the future. Always Dr. Aravindan say that the future of pathology may be in the apart from the IHCs, and you see that it is on the molecular techniques. So maybe the youngsters will learn much in the coming future. Okay, thank you, Raju, and thank you, Girish, and thank you, Jayalakshmi, for the wonderful sessions.
Thank you, everyone. Have a good rest of the weekend and the wonderful talks to come tomorrow.
Where is Savita? Amrita, Dr. Amrita. So we are ending the second day session, and tomorrow we are coming with the first session is by Dr. Crane, and the second and third session by the Karthik Ganapati. So thank you, and okay, Amrita.
Yes, thank you, sir. Thank you so much. Thank you once again to all the delegates, all the speakers and all the moderators. I hope the talks were beneficial for all the attendees. So please note that tomorrow's session starts at 6:30 p.m. IST. So see you all tomorrow. Till then, thank you and good night.
So good day, Raju.
Thank you. Bye-bye.
Yeah, bye-bye.
Thank you.
Yeah, good day, Jaya. And Girish also, right?
Yeah. Thank you, Dr. Rajan. Bye. See you
Okay,
tomorrow.
bye. Bye.